Welcome to the December 3rd Quarterly Board of Health meeting. Just to let you know, I call the meeting to order. This meeting is being conducted in a completely virtual environment and is being recorded. There are several things that we'd like to review before we get started. First, the names of all the board members, along with the constituency that they represent, are displayed on the screen. In addition, there are several staff members from the Virginia Department of Health and Office of the Attorney General who have physically assembled at the Madison Building in Richmond for this meeting. To comply with the governor's orders on social distancing and masks to limit the spread of COVID-19, they will be wearing face coverings and sitting 6 feet apart. The list of all staff participating in this meeting is displayed on the screen. Several of these staff members are participating virtually. Lastly, all votes that are taken by the board during today's meeting will be roll call votes. I will be restating the names of the members who make the motions or seconds. Attendees, you will not be able to unmute yourselves. When we get to the public comment period, you will be unmuted by the host if you have signed up to speak. With that being said, Ms. Jansen, please call the roll.
All right. Mr. Kreitzer?
I'm here.
Mr. Kreitzer? Thank you. Mr. East?
I'm here.
Thank you. Mr. Edmondson? Mr. Edmondson?
I'm sorry. I'm here.
Thank you.
So is my dog.
Ms. Hines, I know will be late. Ms. Harrison? Ms. Harrison?
Lisa?
Dr. Jang?
I'm here.
Here.
Excellent. Thank you. Dr. Kinzer?
I'm here.
Thank you. Dr. Klein?
I'm here.
Thank you. Dr. Miller? Dr. Miller? I see you.
Here.
Thank you. Thank you. Ms. Pritchard?
Here.
Thank you. Dr. Purett?
Here.
Thank you. Dr. Schuler? Dr. Swartz?
I'm here.
Thank you. Ms. Waddell? Okay. And Ms. Whipple?
Present.
Thank you. Madam Chair, there is a quorum.
All right. Thank you very much, Alex. Now time for Mr. Hilbert to review the agenda for today's meeting.
Good morning, Madam Chair and members of the board. The agenda is displayed on the screen. First item is we're going to be presenting a proclamation in memoriam of Bruce Edwards, our former board chair who passed away earlier this year. Ms. Pritchard will be presenting that. We'll then review and approve the minutes from the last meeting. Next item will be the Commissioner's report from Dr. Oliver. We have a break scheduled, and then Dr. Jeng will be giving an informational briefing on wastewater monitoring for COVID-19. Following that, I will present the regulatory action update. Next slide, please. We then have our public comment period scheduled. After another short break, we'll move into the regulatory action item portion of the agenda. We have 3 actions to bring to you today. The first is final amendments to the waterworks regulations. Dwayne Roadcap will be presenting those to you. We then have fast track amendments for regulations for an adult comprehensive sickle cell clinic network. Heather Board will be presenting those to you. And then following that, Ms. Board will also be presenting proposed amendments for regulations for state certified doulas. And following another short break, we have our Dr. Folano will be presenting the Board of Health Annual Report, which is the update for the Virginia's Plan for Wellbeing. So she'll be presenting that. Next slide, please. We then we'll have a budget update from Stephanie Gilliam, and I will provide then a legislative update looking back on what transpired during the 2020 special session. And then following other business, we will adjourn. And Madam Chair, as part of that budget update and legislative update, we'll be giving the board an update on the status of the recommendations, the policy recommendations that the board sent to the governor in late September. Madam Chair, if there are no questions, that's the agenda for today.
All right, are there any questions for Mr. Hilbert? All right, thanks, Joe. As Joe mentioned, we have a proclamation this morning for our friend and colleague, Bruce Edwards. I know that Bruce left a mark on VEH that none of us will forget. And as our friend, we miss him, and as our colleague, we miss him. And so we have put together a resolution for him, which I will read, and we will send an official copy of this to his family as well. Whereas Bruce Edwards, a husband, father, teacher, and mentor, passed away peacefully from his family and friends on August 22nd, 2020. And whereas Bruce Edwards, a gentleman dedicated to the spirit of the common good in Virginia, gave freely of his time and talents in service to the Commonwealth on the Virginia State Board of Health. And whereas Mr. Edwards served on the State Board of Health as a representative of the emergency medical services community from 2009 to 2017. And whereas Mr. Edwards started his emergency medical services career with the Ocean Park Volunteer Rescue Squad in Virginia Beach in 1967. And whereas Mr. Edwards received a bachelor's degree in secondary education and a master's degree in public administration from Old Dominion University. And whereas Mr. Edwards was named Director of Emergency Medical Services in Virginia Beach in 1984, serving with distinction for 33 years prior to his retirement in 2017. And whereas Mr. Edwards served on the State Emergency Medical Services Advisory Board from 1991 to 1997, and again from 2006 to 2012. And whereas Mr. Edwards served as chair of the State Board of Health from 2011 to 2017. And whereas Mr. Edwards consistently provided the Board of Health with strong, steady leadership as chair and constantly demonstrated a high level of energy, commitment, and determination in guiding the board's deliberations on significant public health issues. And whereas Mr. Edwards' keen intellect, diligent preparation, sense of fair play, and knowledge of proper parliamentary procedure enabled him to guide the Board of Health through often complex and contentious public health policy discussions. And whereas shortly after his passing, the Virginia Beach City Council renamed the EMS Training Center as the Bruce W. Edwards Virginia Beach Emergency Medical Services Headquarters and Training Center in his honor. And whereas Bruce Edwards will also be missed, remembered, and live on in the stories told by his numerous friends and colleagues. Now, therefore, be it resolved that the State Board of Health hereby notes with great sadness the loss of Bruce Edwards, a respected leader in Virginia's emergency medical services and public health community. And be it resolved further that the Virginia Department of Health prepare a copy of this resolution for presentation to the family of Bruce Edwards as an expression of the Board of Health's respect for his memory. Signed by me. Do we need a motion to accept that proclamation?
No, ma'am. Just by general consensus, we'll accept it.
Thank you very much. You know, Bruce liked to say that a lot of people were OCD, but he was CDO, and that was OCD with the letters in the correct order. So I want to make sure when we do this that we do it as he would have had it done. So thank you very much. It's now time for the approval of our September 3rd, 2020 minutes. If I could have a motion to approve in a second.
So moved.
I'm sorry, who was that? Was that?
Molly.
Okay, and there's the second.
Second, Wendy Klein.
So we have a motion and a second. Is there any discussion? All right, all those in favor. Are we doing roll call today, Alex? I'm sorry.
Yes, ma'am.
Okay, then Alex, if you could take us to the vote, please.
Absolutely. Mr. Kreitzer?
Yes.
Thank you. Mr. East?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. I'm going to skip Ms. Hines, Ms. Harrison,
Lisa, you're on mute. Okay.
Ms. Harrison,
She's raising her hand. Yes, she can't get her mute button off.
okay. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Piritz?
Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell? Ms. Whipple?
Yes.
Thank you. Madam Chair, the motion is 13 ayes.
Thank you very much, Alex. All right, we will now come to what most of us are waiting for, is the commissioner's report. Norm, we're delighted to see you this morning, and I'm going to mute while you speak, just to make sure we don't pick up any of my dog noise.
Thank you. Can you hear me okay?
Yes.
Okay, wonderful. Good morning, Madam Chair and members of the board. I'm really happy to have this opportunity to give you an update on what's been going on in the COVID-19 pandemic response. The next slide, it just shows the number of items that I'll be touching on in the course of this talk. We can go to the next slide. This is an epi curve that shows the course of the pandemic in Virginia from beginning until just a week or so ago. So it has the latest data in it and shows a moving average of the number of cases by date of onset. Virginia reported its first case of COVID-19 on March 7th of this year, and the case counts quickly rose, as you can see here in this epi curve. On April 1st, the governor issued a stay-at-home order in an attempt to try to deal with that rising number of cases. By May 14th, Virginia was beginning to look towards some reopening of the state, and the governor launched the Forward Virginia initiative and began to gradually loosen the restrictions that had been placed on Virginians in an attempt to control the spread of the virus, and then proceeded in a stepwise fashion over the course of the summer to ease those restrictions more and more, as you can see with phase 2 and the phase 3 restrictions, which we are pretty much still adhering to at this point. All of these things were aimed at helping to control the spread of the SARS-CoV-2 virus, which causes COVID-19. After we had initiated phase 3, there was an uptick of cases in our eastern region in the late summer, and temporary enhanced restrictions were put into place to try to control that. We had alcohol sales curfew, we had enhanced enforcement of the mask mandate, gathering size limitation was reinstituted there, and a number of other steps were taken for approximately 1 month, which helped to curb the spread of the virus in the eastern region. More recently, we've seen cases increasing statewide since late October, driven largely by substantial community transmission in far southwest Virginia. Although the increasing case counts are now occurring in every region of the Commonwealth. We've seen the largest numbers of cases in the entire pandemic, as you can see here in this epi curve. As a result, the governor on November 16th initiated additional temporary restrictions via an amendment to Executive Order 67, which is still in place. The impact of that will be seen probably in the next week. Although we also know that with Thanksgiving and the coming December holidays, that we may again see another uptick in cases. Can I have the next slide, please? The pandemic has had a disproportionate effect on populations throughout the Commonwealth, as you are well aware, as we've discussed many times in this Board of Health, that the impact of all diseases have inequitable effects on particularly African American and Latinx communities, and that's been proven true in the COVID-19 pandemic as well. Over 24% of the cases and of the hospitalizations are among Latinx populations, but the Latinx population only accounts for 9.8% of the population in the Commonwealth. 23% of the cases and 30% of the hospitalizations, 26% of the deaths are among African Americans, but African Americans only make up 20% of Virginia's population. 37% of the cases are among people who are aged 20 to 39, while 74% of the hospitalizations are among people 50 or above. 91% of the cases are in people younger than 70, while 74% of the deaths are among people 70 and older. Next slide, please. You will recall that early in the pandemic, we, like other states, were faced with very short supply of materials needed for adequately testing the population. Thankfully, that turned around at a certain point, and we've been able to ramp up testing here in the Commonwealth. And we've continued to increase our capacity to do the PCR testing. And the most recent data will show that we've been averaging well over 20,000 tests a day. And this graph shows that what that total testing looks like across the Commonwealth by healthcare facilities, other healthcare providers, local health departments, retail pharmacies, and so on. We've also been able to distribute that testing fairly widely across the Commonwealth, which you can see in the next slide, the map that depicts the testing locations and daily cases per 100,000 across the state. So that you can see that in virtually every county, there are testing sites that people can easily reach. Next slide, please. One of the other things that has come on board in the testing front is the advent of the antigen tests. These are rapid point of care tests that allow for testing for the virus or for pieces of the virus in 15 minutes to an hour. The disadvantage to these tests is that they are prone to higher rates of false positives and false negatives, which raises some problems and challenges in deciding when and in what particular situations you would want to use these tests. The HHS, Health and Human Services at the federal level, distributed to nursing homes in the Commonwealth the machine for doing the Veritor test, which is one of these antigen tests. Virginia participated in a multi-state collaborative that allowed us to buy supplies for the BD Veritor system. So in addition to what was received by the skilled nursing facilities for testing using these machines, the state also provided 239,000 of these tests to nursing homes across the Commonwealth. HHS also bought the Binax Now antigen card, which is another one of these antigen tests. And Virginia will be receiving close to 3 million of them by the time we get all of our allocated Binax Now cards. And we have been able to distribute, as you can see here, a number of these cards, thousands to DBHDS, the Department of Corrections, Department of Military Affairs, free clinics. We've distributed to VHHA for the hospital systems, 100,000 tests. We did 100,000 to institutes of higher education, and another 100,000 to local health departments. We've also managed to come up with an agreement to send close to 100,000 to retail pharmacies. We're in discussions now with primary care networks to distribute hundreds of thousands of these tests to primary care providers as another way to improve the ability of healthcare providers around the Commonwealth to test people for COVID-19. Next slide. In our attempt to box in on the virus and try to contain it, obviously the first part is to test people to see whether or not they have COVID-19. And after testing them, then isolating people who have the virus and finding out who their contacts were, who they may have exposed to the virus, and then quarantining those people. And that whole process is our containment program. Virginia's local health departments hired nearly 2,000 people. It was well over 1,700. It was really more like 1,800 in the course of just a few months since June. We used the Coronavirus Relief Fund from the CARES Act to make this possible. We also entered in agreements with 4 colleges and universities to augment contact tracers on campuses around the Commonwealth. And we're establishing a team now in each district to augment the district operations when cases are surging. Next slide. As of December 1st, local health departments have enrolled over 190,000 people, as you can see here, in our contact tracing monitoring program. And we've done a very good job at reporting on these folks that we're monitoring through the containment program, with 72% of the cases that are reported to VDH within 24 hours to conduct a case interview and identify close contacts. While a minority of contacts are not reachable, over 90% of those who are reachable were contacted within 24 hours. Next slide. Virginia was the first state to launch an exposure notification application. These applications now exist in about 20 states, I believe. The exposure notification applications that use the Google Apple API are noteworthy for being able to track COVID-19 without tracking people. And that's in order to ensure the privacy of individuals who use these applications. We are now at about 164,000 downloads of the application. And we are keeping track of that in the same way that Google and Apple track app use, which is to look at the population 18 to 65 with smartphones. And we are about 1 in 5 of those people have downloaded our app, which is called COVID Wise. Next slide. As you are well aware, one of the biggest impacts of the COVID-19 pandemic has been on our long-term care facilities, both the skilled nursing facilities and the assisted living facilities. And this slide depicts a number of different aspects of that. They've been significantly impacted, and as of December 1st, the outbreaks in long-term care facilities represent 37% of all the COVID-19 outbreaks in Virginia to date. That's been particularly noteworthy in some of the surges that we've seen in community spread. What this slide illustrates is the number of outbreaks each month. That's the orange line. The average number of cases for each outbreak, which is the blue bars, and the average number of deaths per long-term care facility, which is the gray bars. The number of outbreaks in long-term care facilities peaked in April, which had 98 outbreaks in these facilities, and it's been pretty variable since that time. The average number of cases per outbreak has been trending downward, as you can see in that orange line. The highest average number of cases occurred in that March-April period, which both had an average of 47 cases per outbreak. There was another peak in July, with an average number of cases of 27. The average number of deaths per outbreak has been slowly trending downward since April, as you can see in this with the blue bars there, gray bars. The average, now although the long-term care facilities our outbreaks are still happening and are very concerning, the declines in the average number of cases is an improvement, and this demonstrates, I think, our increasing knowledge of the virus, our increased testing capacity, which allows for early identification of the cases, and a focus on infection prevention and infection control strategies to help control the spread within these facilities. And that's been a real noteworthy amount of work on the part of the health department, our long-term care facilities task force, and on the staff and administration of these long-term care facilities. I think it's worth noting that the outbreaks in the long-term care facilities have been different in different regions at different times during the pandemic. So in the early part of this pandemic, when we saw the biggest surge of cases in the northern part of the Commonwealth, the outbreaks in nursing homes and assisted living facilities were concentrated in that area. When we saw this surge in July in the eastern region of the state, the outbreaks concentrated there, and likewise with our current surge, we are seeing the cases be, the outbreaks rather, really focused a lot in our southwestern region. So the take-home message there is that outbreaks in the long-term care facilities are a reflection of what's happening in the community. When you have widespread community transmission, that spills over into settings like nursing homes, other congregate settings. Next slide, please. As I said, the long-term care, the governor's long-term care task force has been very instrumental in helping us to improve the situation in the long-term care facilities in the course of this pandemic. This task force was convened with a number of stakeholders, providers, agency staff to monitor what was going on in the long-term care facilities and then assure that those facilities got the necessary resources and expertise that they needed to respond to the pandemic. It's met very frequently since April. And as I said, it's multiple committees around communication, care transition, infection control, PPE, employee wellness. All of these things have contributed, I believe, to the improvements in what's occurred in our long-term care facilities since the beginning of the pandemic. On testing, we have, of course, focused on following the CDC and CMS testing guidance, which is related to percent positivity in the surrounding community. And as that percent positivity goes up, the amount of testing of residents and staff goes up as well. We've asked all the assisted living facilities and skilled nursing facilities whether they wanted point prevalence surveys conducted in their facilities. A point prevalence survey is when you test everybody in the facility at one time. And we've conducted, as you can see here, in these surveys in 87% of the nursing homes and 40% of the assisted living facilities. And that's we didn't do all of them because not all of them wanted to have such a test done or had already conducted their own test. As I mentioned, infection control has improved greatly in the nursing homes. And the biggest challenge that they've faced really has been and continues to be on the issue of staffing and workforce. These have been issues that were plaguing long-term care facilities before the COVID-19 pandemic, but the pandemic has made it worse when staff have had to be isolated or quarantined. It put great pressures on these facilities. We've tried to step in to help with the Medical Reserve Corps, providing volunteers to fill critical workforce gaps. And the governor's administration, as you will recall, provided some much needed funding from CARES Act dollars to help support these workforce needs as well. Next slide. In addition to our efforts around containment and dealing with the outbreaks, we have been very active in proposing and helping to enforce community mitigation measures to help tamp down the spread of the SARS-CoV-2 virus. Community mitigation activities are actions that people and communities can take to slow the spread of a new virus in a pandemic that has pandemic potential. So it includes strategies like the stay-at-home order, restrictions on businesses like closing restaurants, reducing occupancy in restaurants, or limiting the size of social gatherings, and so on. They're especially important in those times when there are no medical interventions that are available. We don't have a vaccine. There's no therapeutic drugs that are widely available. However, I would point out that even in the situation where you have the development of a vaccine, which we now have with COVID-19, that many of these measures will continue to be needed well into the vaccination campaign. The basic prevention strategies that are used in community mitigation are, first of all, at the individual level, we need to ourselves, of course, be responsible and follow healthy hygiene practices. Wear a mask, wash our hands, watch our distance from each other, and make sure that we're physically distant. These universal precautions are appropriate regardless of the extent of additional mitigation that is needed. The other mitigation strategies need to be based on real good data, or they should be based on the data, so that we can be as precise as possible. They need to be tailored to the needs of each community and implemented in a manner that minimizes both the morbidity and mortality from COVID-19 and does not inadvertently create or exacerbate any health disparities. And this can be a difficult and challenging balance to strike at times. To help guide these complex decisions, VDH has established its pandemic metrics dashboard to provide key data and information to stakeholders across the Commonwealth. We've partnered with stakeholders in the business community, the Secretary of Commerce and Trade, and the Department of Education, in addition to local school superintendents and industry partners. As part of this, you'll find on our pandemic dashboard links to key mitigation documents and various sector-specific guidance around the schools, for example. These frameworks use objective thresholds based on disease data and healthcare capacity and preparedness, and are balanced with public acceptability and economic impact to identify when measures should be tightened or loosened. So we have a community mitigation framework document that deals with workplaces, large sporting events, that sort of thing. As I said, the community mitigation team has worked very closely with the our partners in commerce and trade to see to make sure that the impacts that we are looking at on the business community aren't. We want to balance containing the disease as much as possible with not closing everything down. Anyway, next slide. Back in May, the governor issued Executive Order 63 that required face covering. So that was the mask mandate. And in that executive order, VDH was identified and tasked with the enforcement of this mask order. In June, the governor issued Executive Order 65 that further eased restrictions on certain establishments such as restaurants and retail establishments and fitness centers. But this order also provided that VDH would be tasked with the enforcement of what restrictions were still in place, such as capacity requirements and other social distancing requirements. There have been other executive orders since then, 63 and 67, and VDH was also charged with the enforcement of these as well. Due to the continued community spread of COVID-19, the restrictions in these executive orders and numerous complaints being received in our call center and at the local health departments, VDH created an online reporting tool to more effectively and efficiently get these complaints in. The tool allowed for us to have a central repository of all complaints that could then be accessed by local health departments, environmental health staff, who were the ones charged with this enforcement. As you can see, we've gotten a lot of complaints. As of the first, we've received a little bit more than 53,000 complaints. About 3,600 of those have resulted in enforcement action. Actually, the highest number of complaints we've received have been about 275 per day. That's happening since a couple weeks ago. So that average number has gone up. The frequent areas of concern are about congregation at restaurant bar areas. It's hard to drink beer with a mask. So what's happening is that at these bar and club scenes, you have a lot of folks congregating for a long period of time and they're not wearing masks. And in general, what we've seen in this current surge, as a sidebar here, is the same sort of thing. Indoor gatherings without a mask seem to be the primary places where we're getting spread of the virus. That would be bars, restaurants, gyms, and houses of worship with large congregations if they're not wearing masks. Which leads me to this next slide. The enforcement of the mask order is not the most key way in which we are attempting to get people to change that behavior. In order to get them to actually take the responsibility to wear the masks and wash their hands frequently and maintain physical distance, we've ramped up our communications effort, which this slide depicts. We've assembled a communications team specifically for the COVID-19 response. We've launched a public awareness campaign. Virginia's health is in your hands, and a mask up campaign, which has been tailored in different regions, recognizing that we need to speak to the cultural differences in various regions, understand what's really driving some of the behavior and try to address it that way. We'll be doing a number of what's called satellite media tours. This is when one of us will sit down for about 6 hours straight and one after another do interviews on multiple radio, TV, and other news outlets. We're also establishing a official public relations and marketing plan for all active public relations vendors and who are involved in our COVID-19 response right now, so that we can coordinate the work that they're doing to ensure that the consistent public health message is getting out in all of those initiatives.
Dr. Oliver.
Yes.
Dr. Oliver.
Yes, Dr. Schuler.
I really want to commend you and the staff for the excellent number and quality of the advertisements that you put into the newspapers and local TV here in Southwest Virginia. It's really impressive, and I want to thank you and all the people that are working with you to put this forward. Hopefully, we will continue to make some dent into those people that don't believe in masks, hand washing, and social distancing. So whatever you can do to keep it up. I see you've got a 2021 budget request in for additional resources, and just thank you very much.
Well, thank you for that comment. I mean, that's been an example of one of those targeted campaigns. We knew that while the cases have been going up greatly across every region in the state. That's been particularly true in far southwest Virginia. So we did, in fact, launch a specific campaign there around Mask Up that was, very targeted to that area. So I'm glad that you're noticing it, and I hope other people will notice it. And like you said, take the message to heart. It's particularly challenging, not just because of those individual behaviors, but as you probably are well aware, we have we're dealing with the fact that in Tennessee, Kentucky, and West Virginia, they're not taking the same sort of steps, right? There's no mask order in Tennessee. It doesn't have the same sort of restrictions that we have. So while here in Virginia, our case incidence is somewhere around 28 per 100,000. It's about 60 per 100,000 in Tennessee. And with all the back and forth for work and visiting family and so on, that's also contributing to the pressures that you all are seeing in Southwest Virginia. So it makes it even more important for us to take those individual actions as well as the community mitigation there. I appreciate your comments very much. But there's some hope around the horizon, perhaps as early as next week. Let's go to the next slide. As you know, there are a couple vaccines that will be coming our way. I think it's important before talking a little bit about our vaccination campaign, just to go through the vaccine life cycle here. There's been a lot of concern about the development of the COVID-19 vaccines. I don't need to remind you all that this process has been highly politicized, and that factor has made it even more understandable in a way that people have some concerns about this process. But the truth is that the COVID-19 vaccines underwent the same very rigorous process of development. And you, at your leisure, take a look at this. Every single one of these steps are steps that have been taken to develop the vaccines that are coming down the pike for COVID-19, and all the political drama around it was really taking place outside of this normal vaccine life cycle. To the extent that these vaccines were developed more quickly, it's really a difference in the science since the development of the last vaccine, which was the MMR vaccine, probably about 40 years ago. So, science has come a long way. These are different types of vaccines than the live or attenuated virus vaccines, and we were able to pull them together more quickly. The other thing that happened, of course, is that the federal government provided a lot of money, a lot of capital to allow these vaccines to be manufactured in mass quantities. The Operation Warp Speed has been very helpful in this regard. So that what will happen is that as soon as these vaccines are found to be safe and effective by the FDA and ACIP, that they will then be able to ramp up quickly in providing the vaccine to the states for their vaccination campaigns. Next slide. That vaccination campaign will be carried out in a number of phases. The initial phase of the vaccination campaign will be focused on, first of all, the healthcare workforce, and following the healthcare workforce, or at the same time, really, we'll be dealing with long-term care facilities. The ACIP recommended several days ago that we focus first on the residents of long-term care facilities, and that we will be using the ACIP recommendations as our guide. So we'll, in phase 1A, be focusing on healthcare workers and on residents in long-term care facilities. We will then move in phase 1B to critical workforce and other essential workers. And then we will move into dealing with the medically vulnerable populations, people with chronic underlying conditions, and put them at higher risks of mortality from COVID-19, and people over the age of 65. Around that time, we expect that other vaccines will be coming on board in addition to the Pfizer and Moderna vaccines. And we'll have, with that additional supply, the ability to broaden out and deal with other priority populations, and then branch out even more to deal with the general public. We expect to get the first vaccine by mid-December. As you know, Pfizer has already applied for its emergency use authorization from the FDA. I believe they're meeting tomorrow to consider that. As soon as they make their decision, Pfizer says they can immediately start shipping vaccine. And our allocation of the Pfizer vaccine is about 70,000 doses, a little bit more than that. Moderna has also now applied for its EUA, and that would mean that their vaccine could be getting to us by the end of December, and we'd have then 2 vaccines to utilize in the campaign. Next slide. The COVID-19 vaccine was purchased with U.S. tax dollars and will be given to all Americans at no cost. However, vaccine providers will be able to charge an administration fee for giving the shot to someone. They'll be able to get this fee reimbursed by patients' public or private insurance, or for uninsured patients by the Health Resources and Services Administration, which has a provider relief fund. So people should be able to get the vaccine at no cost, whether or not you have insurance. All the providers who are going to be giving the vaccine are required to report who gets vaccinated, when, by whom, and with which vaccine, and that information will be then inputted into our Virginia Immunization Information System, the VIS, which is the immunization registry that VDH has. What this slide depicts here is our prioritization algorithm or protocol for dealing with vaccination. Once the vaccine is approved, and we will take the ACIP recommendations on the priority groups. The CDC will allocate the vaccines to the states on the left-hand side there. We will use those recommended priority groups to then decide who gets that limited resource. We expect the demand for the COVID-19 vaccine to be high, and that it will outpace the supply, at least initially. So the ACIP that I keep mentioning, that's the Advisory Committee on Immunization Practices, and that's the group that we follow on all vaccines. So our childhood vaccination schedule is a schedule that is the one that's recommended by ACIP. Virginia's Unified Command has developed this process that's depicted here in this chart in order to really help ensure that we do this in an equitable fashion. Go to the next slide. So if there's a sufficient amount of vaccine to cover the entire priority group, it will be shipped directly to the designated vaccinators to administer. You remember in phase 1A, the vaccines are marked for healthcare workers and for residents in nursing homes. In both situations, the will happen is that we'll be able to get those vaccines directly to those sites, to the hospitals. And can you go back to the previous slide? I'm sorry. And there will be, from the feds, the CDC will allocate to, on that right-hand arm of this, you'll see that they allocate vaccines to pharmacies. They have an arrangement with Walgreens and CVS to do the vaccinations for long-term care facilities. So healthcare workers and long-term care facilities will then be able to get that vaccination to occur. Next slide. So if we have a sufficient amount, we will be able to do everyone in those two sites. If not, then we're going to have to do one of these two pathways that you see here. For the initial shipment of the Pfizer vaccine, which is an ultra cold vaccine, the Virginia Hospital and Healthcare Association has provided a protocol to the health systems that's been approved already by the COVID-19 Unified Command's Virginia Disaster Medical Advisory Committee, or VDMAC. This group, if you don't recall, was established in the spring to help us make decisions about scarce resources. It includes public health, other healthcare providers. It has some medical ethicists, some legal representatives, some community groups, the health equity work group, and others. And if in the future we need to identify any other subgroups that we want to target for the vaccination, the vaccine unit will draft a protocol, elicit comments from the Vaccine Advisory Committee that we've established, and provide both of those recommendations and those comments to the VDMAC for final determination. So as you see in this chart here, what occurs is if there's not a sufficient amount for the entire group, then we'll either have health system workers, we'll define subgroups within the healthcare workers, and then distribute the vaccine along that protocol. And in turn, on the right-hand side, we'll do the same thing with other healthcare workers, critical infrastructure, and medically vulnerable, and other priority groups. Next slide. We'll be working very quickly to allocate all of the vaccines that the CDC allocates and provides to Virginia. The two manufacturers, as you know, that have vaccines right now are Pfizer and Moderna. There's a bunch of challenges to dealing with these vaccines, and some of them are listed here. The Pfizer vaccine requires ultra cold chain supply chain. It needs to be stored at minus 94 degrees Fahrenheit, minus 80 centigrade. and that we've identified a number of sites around the Commonwealth, I think about 25 at this point, that have ultra cold chain storage capabilities, and those will be the sites where we will put this Pfizer vaccine and then distribute it from there to the identified population to be vaccinated. The other complication is that they require 2 doses, and the 2 doses are about 3 weeks apart from one another. And the interval is different for each. So one vaccine, you have to get the second dose 21 days after the first, and the other vaccine, you have to get it 28 days after the first, which presents a number of logistical challenges and requiring us to really have excellent data management, knowing who got what dose where, so that we can ensure that they get the proper second dose, because they're not interchangeable. Next slide. Carrying out the response to the COVID-19 pandemic has been a real challenge in terms of the amount of work that we all have been doing, and also in terms of the resources that have been required. This slide summarizes the CARES Act funds that have been directly allocated to VDH. It includes funding provided to VDH as passed through to another entity, such as the Carilion healthcare system, or universities that we were utilizing for testing, and we wanted to reimburse them for that. We also have received some grant funding to help with our COVID response, and there's a grant we get from the CDC around epidemiology and laboratory capacity, the ELC grant. And you'll see there that some of the funding that had been used from the ELC grant, we were able to replace with funds from the CARES Act dollars. One thing I should say about the CARES Act dollars, the CARES Act was passed in the spring. We didn't get the money as a state for that until April. There were a lot of uncertainties with the guidelines that were provided from the federal government about how these funds could be used. And in dealing with that, the state did not disperse to us a lot of these funds until September and October. So we've only had a lot of these funds for a little over a month, and we have to spend it all by December 30th, which is going to be a real challenge to do, but we are gearing up to do the best that we can in that regard. Next slide. In addition to the CARES Act money, there has been some funding that we've received from direct federal grants, which we outlined here. I mentioned the ELC grant. There's been some other funds for immunizations and emergency preparedness that we were able to utilize. Just to give you an idea of the kind of resources that are being allocated to this, the grant dollars continue into 2021. The CARES Act dollars at this point are to be spent by December 30th. And there's no new federal funding that is earmarked as of yet. It is our hope, as is the hope of other states, that the federal government will, in fact, come up with ways in which to provide funding for the vaccination campaign and continuation of our containment efforts against the virus causing COVID-19. And hopefully that will happen with the incoming administration. Even if it does, there'll be a gap. And the Northam administration has said that they will think of ways to provide some funding to fill that gap. And they're working on that now. Next slide. So what have we learned? I think the importance of these prevention strategies are still paramount. Wearing a mask, watching our distance, and washing our hands, staying at home if we're sick. These things will have to continue. They'll have to continue for long into the vaccination campaign. And that's going to be a very important message just because we know the vaccine protects you from COVID-19. It's effective in that regard. We don't know that whether or not the vaccine will actually stop the spread of the virus. That wasn't what it was tested for. It was tested to see whether or not it would prevent individuals from getting COVID-19. I think it's going to be important to really continue to wear masks, wash our hands, and watch our distance. We'll have to continue to do the containment, early identification of cases through our testing efforts. And then once we identify cases, isolating them, identifying their contacts and quarantining those contacts. For both the vaccination campaign and our containment efforts and prevention efforts, we're going to have a really great communications. It's absolutely essential. And the communications needs to be more than just a marketing and PR effort. It's got to be a community outreach effort. The communities that are most vulnerable to COVID-19 are the ones that are, in fact, the most, I'm trying to think of the best way of putting this. Vaccine hesitancy is the greatest in the African American Latinx communities. It's probably also the case in rural communities. The mask wearing in the Latinx community is really a challenge. There's a lot of resistance to that. We know that in Southwest Virginia and other rural areas, wearing masks has been a real, getting people to wear masks has been a real challenge. So on the one hand, these communities are the most vulnerable to the virus, but on the other hand, the things we need to do to protect those communities from the virus are less taken up there. And we need to, and that's where the community outreach is really, really important. Getting trusted leaders in those communities to speak out about the importance of adhering to individual prevention, hygiene behaviors, and the importance of getting the vaccine will be critical to the success of both. And I think all of us are experiencing some COVID fatigue. We've been at this for a long time, since March. So there's fatigue, there's some complacency. And the impact of the pandemic on the healthcare workforce has taken its toll as well, with making it more difficult. For example, in Southwest Virginia, Ballot Health is having some difficulty in ensuring they have adequate healthcare workforce in acute settings. So we have a vaccine on the near horizon. And although there's a lot of logistical challenges to ensuring that we get this vaccine into the arms of residents in the Commonwealth, we're prepared to do that. And hopefully, as we do that, we can turn the corner and get back to a near normal existence with the COVID-19 pandemic behind us. And with that, Madam Chair, I'll in my comments, and I'm glad to answer any questions or hear the comments of the board. Thank you.
Thank you, Dr. Oliver. This is a phenomenal lift on your part and all of our folks at BDH. And I just want to say that we are incredibly grateful for the amount of work that has gone into this, knowing full well that you had a pretty full plate before this started. So I'm sure that we all have a lot of questions. And I think Dr. Oliver, would you prefer that we ask questions before we took our break? It is 10:30, or would you prefer that we took a short break and came back?
Oh, thanks for that. Maybe take a break first. I did want to say thank you for your comments about all the hard work that we're doing. It's certainly true. I'm really, really, really proud of the public health workforce. I've always been proud of them, but what they've done in response to this pandemic is just mind-boggling. People are working 24/7. They've been doing it since actually before March. The GA session was not a cakewalk either, right? It was a lot of work too. So they've been really at it since January, and this is their passion. They've really thrown themselves into the work. They have shown themselves to be the most dedicated of public servants, and so we thank you and others whenever they recognize how much work they've done, and it's really those people in the front lines, in those local health districts who have been the ones who I think are responsible for saving thousands of lives here in the Commonwealth of Virginia. So thank you for that. Yeah, let's take a break and then come back and do the question.
So let's say about 10 minutes, and we'll come back. Gary has the first question because he's the fastest on the chat button. And I will see you guys in just a little bit.
Okay.
Okay. And Dr. Oliver lets me know he's back. We will start. Gary, are you also back?
I am back.
Yes, ma'am, I'm back.
All right. Well, Dr. Oliver's back. Gary's back. I don't know that there's one super efficient way to do this, but if you're able to, it might be easier if you chat me your request to go next. And I think the that currently is Gary and then Elizabeth. I'm sorry, Lisa. Sorry, it comes up as Elizabeth. So, all right. So Gary, go first.
Thank you very much, Faye. Dr. Oliver, thank you for that wonderful report. And I'd like to echo Faye's comments about the exceptional work that VDH has done, all of your staff, the personal experiences I mentioned last time with the Central Shenandoah Health District has been outstanding, and we're very grateful for all of your efforts. The one question that I had was related to the vaccination priorities. And certainly my interest is in whether EMS providers will be included as healthcare providers in the first vaccination rollout. They're certainly on the front lines encountering these COVID or COVID-like patients or confirmed COVID patients in uncontrolled environments and is a very limited workforce, just as our healthcare workers. So I'm interested in where they rank in the priorities of getting the initial series of vaccinations.
Thank you, Gary, for that question. They are included in phase 1, but as you know, the vaccine amounts that we receive will be limited. So not all healthcare workers will get it. Initially, we'll have to come up with some subgroups within that. I don't know if Lillian, Dr. Peak, our state epidemiologist, or Christy Gray, the head of our division of immunization, is here. But so if we were to divide that up into phases 1A and 1B, 1C, like that, in one of those phases, we would be getting out to first responders. So that group will be in the initial group that we vaccinate, and perhaps not the very first ones to get it.
Okay, thank you very much.
Okay, Lisa's next, and then Stacy's after Lisa.
Okay, hi, can you hear me?
Yep.
Okay, good. Dr. Oliver, I hesitate to even ask this question, and I hope I don't get death threats and hate mail for bringing it up. But one thing, this is also about the priority for distribution of the vaccine. It just occurs to me that, of course, healthcare providers, A, B, and C, you know, they need to be the first up and online to be served. I have a little bit of a problem with the resident population of long-term care only, and again, I don't want to sound kind of glib about this, but they are already a kind of a self-quarantined environment, kind of in a bubble already, and it makes perfect sense for staff and the healthcare workers who are going in and out to be vaccinated. But that resident population, and even by your charts and numbers, you see how dramatically those numbers have declined, fortunately. But I question that. It just seems like there are a lot of other at-risk populations, people with underlying conditions who are still in the workforce, that sort of thing. This seems like it takes a lot of the vaccine, which is so limited in this first run, to a population that is already kind of pretty successfully quarantined. What do you hear anything about that, or is there any discussion or thought?
The rationale for it has to do with the extreme vulnerability of that population. So while it's a relatively small number of people, they make up, basically more than half of the deaths, and that's an exaggeration. So almost half of the deaths that we've experienced from COVID-19 have been in long-term care facilities. So we're talking about a population that is very, very high risk. And the population, if you take all of the healthcare workers and all of the long-term care facilities and put them together, it's about 500,000 people. We believe we can get that done in that phase one, and then move on to the other vulnerable populations as the production of the vaccine ramps up.
Okay, thank you very much.
Okay, Stacy is next.
Thank you so much. Dr. Oliver, as you're sure you can imagine, pharmacies are getting lots of questions about vaccine. I think people are going right to phase 2. And there's definitely a lot of questions about what that's going to look like. So I just have a specific question, or 2 specific questions for you. Phase 1 seems like it's going to be very, closed distribution, as well it should, with parameters and things like that. But for phase 2, Christy and her team has assured me that you all are trying to cast a very wide net to get a lot of vaccinators. A couple months ago, there was the provider intent form. I just wanted to see if you could share with us a little of your thoughts right now on how you are expecting vaccination to be distributed to non-chain pharmacies and to small doctors' practices and stuff like that for when we get to phase 2, because all appearances for me from reports is that it's not going to go through our normal distribution chains. The people that we buy our flu vaccine, we're not going to be because we're not buying it, it's going to be distributed. So some thoughts on, if you could share with us thoughts on that, that would be helpful. And then my second question is, there's going to be a lot of questions about what medically vulnerable means in phase 2, and how are providers going to be making those determinations about who they should vaccinate, or have you thought about that? Because I think it'll be easier if we can point to, this is the type of person who we need to vaccinate, rather than everybody making their individual cases as to why they're medically vulnerable.
Thank you, Stacy, for that question. Yes, in phase 2, when we're branching out to the medically vulnerable population, what we will do is hopefully ACIP will have some clear recommendations around that, and if we follow those, that will then give us some definition to that subgroup. It's going to be a pretty broad group, right? When you start talking about people over 65 and someone with a chronic disease that puts them at risk of having more morbidity or mortality from COVID-19, that's millions of people. So we'll get the definition from ACIP, hopefully. We will take that, we will discuss it in our vaccine advisory group, which has all these various stakeholders on it. It'll get vetted through there. It'll get vetted through our disaster medical advisory group, and then through the Unified Command, and be approved that way, so that you and other providers who are out there vaccinating people will have some clear guidelines on what to do, and guidelines that have been vetted by a broad enough group of stakeholders that we can feel confident that it's been done through an equity lens and has results in groups defined in such a way that we have equitable distribution of the vaccine. I hope that answers your question. As far as getting a broad enough people, again, like I said, it's going to be millions. We would want to expand to all the pharmacy chains, including those that are independent. We will want to look to broadening out to open points of dispensing. The health department itself is planning on doing open pods, and we're aiming to do about 35% of the population ourselves. So that's how we're going to get all those numbers.
And so you are expecting during phase 2 that the vaccine to go to these smaller providers would come from the health department. Would we get it directly from them? Is that your thought process?
I'm not exactly sure on that. So let me get back to you on that logistical question of how it would be distributed.
Okay, I appreciate it. Thank you.
Mm-hmm.
Okay, thank you, Stacy. Next is Patricia.
Dr. Oliver, thank you for your comprehensive presentation as always. I have a quick question. Given the variety of implementation of in-person versus virtual education across the state, where do teachers fall in with regards to the phases? And perhaps you mentioned it and maybe I missed hearing that detail.
No, I didn't mention it. There, at the national level, there's a list that's provided regarding essential workers. Earlier in the pandemic, when we instituted the various restrictions, and then as we began to ease the restrictions in the Forward Virginia Camp initiative, we did not define essential workers. So we're going to have to do that, and we haven't done it as of yet. I know that the governor considers teachers to be part of that essential workforce, and so I suspect that they will be included in our recommendations. So in which case, when in phase 1, and that they will be part of that critical workforce that we'd want to vaccinate.
Thank you.
All right, thank you very much. I think that's the last person I have in the chat. Are there other questions for Dr. Oliver?
Right, I have a question. I wasn't able to raise my hand. Can I still ask questions?
Okay, Anna, you are next.
Okay. Well, Commissioner Oliver, thank you for presentation. You know, I always appreciate you guys' work. I know you guys work very hard. One question about the vaccination. You know, each individual had to get 2 doses. And I think you probably already thought of this. Some people may not able to follow through the 2nd dose. Based on the data that you provide, the Virginia state will receive over 8 million doses of the vaccine, which is enough to cover all our Virginians. But for those, have you taken into account if those people miss the 2nd dose, because the shelf life for the vaccine is kind of short. You say, 21 days had to follow up. Have you thought about that?
Yeah, we've thought about that a lot. So it's one of those challenges that we are preparing to deal with. So it requires very close tracking of who we've vaccinated with what vaccine, because it's not just that it's 2 doses. The 2 vaccines we have right now have different intervals between the 2 doses, and they're not interchangeable.
Yes.
So if you get the Pfizer vaccine,
you had to stay with Pfizer.
You gotta stay with the Pfizer vaccine, and you gotta get it. I think that's the one that's 21. And then if you get the Moderna vaccine, your 2nd one has to be the Moderna vaccine. You can't change that. So we have a tracking system for that. And we're also looking to augment the tracking system that we have free from the CDC with a more robust systems to ensure that we have the kind of data management capabilities to be able to ensure that we get those people back for that second dose and get them back for the correct second dose. Now, the other thing, as you well know, there are other vaccines that don't have 2 doses that are still in clinical trial.
Yes.
And should they successfully complete their clinical trials and are found to be safe and effective through the FDA evaluation, then that would be great. I got my fingers and toes crossed for that one, because as we ramp up for the more massive general public vaccination campaign, if we have one of those single dose,
make it easier.
It would make it a lot easier.
So if the tracking is a good idea, does the state going to send out like a reminder to those people who receive the first dose?
Again,
invite them back and say, hey, this is to get it. Go ahead.
I think that's going to be on the providers to do.
I see.
But I think I do believe that is that we're capable of doing that through following our registry. So.
Okay.
So, yes.
Thank you for the answer. Thank you.
Thank you.
All right. Is there anyone else?
Yeah,
Jim.
hey, I had my hand raised. I don't know what happened.
Okay, it's real hard for me to see all of everybody at one time. So that's okay. Catherine, you can go first, and then Benita after that, and then Jim after that.
Okay, Dr. Oliver.
So, but the rest of you try to raise your hands if you want me to recognize you.
All right. Dr. Oliver, first of all, I'd like to say I'm sorry I missed a lot of your presentation because my password wouldn't work and I couldn't get into the system. And I always look forward to your presentation the most. So, and I'm sure that I missed a lot. I did get some of it, but I'm just wondering if there's anything of utmost importance that you think that I should tell our constituents about this pandemic that is all of a sudden spreading all over the country. And if you listen to the news, people are truly panicked. They don't know if they need to just stay home in their room and never come out again or what. And we're all following your instructions with the mask and the social distancing and all of that. But is there anything else maybe that Lisa and I should tell the people out there, the Virginians that would like to know more that they can do to prevent this coming into their world?
Thank you. I'm glad that you are feeling that concern and wanting to do what you can to help. I think messaging the need to continue to follow the individual practices around wearing our masks, watching our distance, and washing our hands is paramount. Where we're seeing the spread right now in the Commonwealth of Virginia can be boiled down to indoor social gatherings without wearing masks. So even large private gatherings, dinners with a number of people, going to gyms or restaurants, houses of worship without a mask. These are the places that we're seeing most of the outbreaks occurring right now. And that's what's contributing to the current surge. So we know what works. Most people are doing it, and that's commendable. I don't want anyone to think that that that's not the case. The majority of residents here are doing it. If you go outside of Virginia, you go over into Tennessee, you'd be shocked. I mean, the people aren't wearing masks at all anywhere. And that's not the case here. Most places you go, just anecdotally, people are wearing masks. But not everyone is. And we need to get more people to adhere to those practices. So that's the main thing I think you need to do is continue that message. It works. People need to do it. And we need to keep it up for a while longer.
Do you think that there will be any changes made in what we're practicing right now? I mean, will indoor restaurants, I mean, will that be closed? People won't be able to go. Are there any changes you think? I listened to the governor yesterday and I didn't hear any changes.
In terms of mitigation measures, if things continue to get worse, we could certainly consider closing the faucet more, ratcheting down on things with increased restrictions. So since we know that social gatherings are an issue, we currently have a restriction to no more than 25, I believe, what the executive order says. We could go back to prior number of 10 for social gatherings. We could look again at indoor dining as and possibly have restrictions there. We could reduce the occupancy level for gyms, which is now, I believe, at 75%. We could cut that back. So there are a number of steps we could take. The governor said that he would consider those in the future, depending on how things go. So we'll see.
Thank you so much. And thank you for your leadership.
Thank you.
All right, Benita is next, and then Jim Edmondson, you're right after Benita.
Thank you, Faye.
You're welcome.
So I just want to thank you, Dr. Oliver, and your team for all the work that you've done. It's a Herculean effort, and I know everybody there is incredibly dedicated. So I don't know how we do it without you. So and I know that the vaccination process is going to be another mammoth effort as well. And I know you guys are working really hard at that. Are you able to kind of clarify where dentists and dental care workers fall in the healthcare worker realm in terms of the staging of vaccines that would be accessible for dentists and dental care workers, especially considering that we work with patients, that have no mask on, and we're trying to limit aerosol procedures, and we've done a lot of, sort of infection control practices, but still it'd be good to have some idea where we would fall in that priority.
Thank you for that, Dr. Miller. The definition of the subgroups within the healthcare workforce has not been done. So in much the same way as I was saying in my answer to Gary earlier, we have, with respect to the first responders, I know that I can say that the dental healthcare workforce is considered part of that phase one, but I just don't know exactly where it would fall. We're going to have a discussion on that, run that to our advisory work group, run that to the medical advisory council, and try to delineate those subgroups within the healthcare workforce and figure out what order we're going to do them in. But we haven't done that yet. It's going to be done in the next several days, however, because we're going to start getting the vaccine within a week or two. and we need to then, and it's going to be scarce. So therefore, we're going to have to know which subgroups to hit in that order.
Yeah.
So that's going to be coming. So we'll be transparent about it. I mean, once we determine that, it'll be, you and others will know what that order will be.
Okay. And so somewhere in phase 1, but in the subgroups somewhere in there. Okay.
Yes.
Thank you. I appreciate that.
All right, Jim, you're next.
Okay. Am I able to be heard?
Yep.
Yeah.
Yep.
Excellent. Well, I've got some observations and a bunch of questions. I actually tuned in yesterday to the national conference call of the COVID task force. I found out about it sort of belatedly, but I listened, and it included Dr. Birx, Dr. Fauci, and a rear admiral who's basically been placed in charge of the logistics of getting vaccines out. There were just some interesting facts that were new to me, I guess, in their consequence, and there weren't things that Norm specifically mentioned, but they certainly relate to all of the briefing that he gave us. One is that Dr. Birx thinks that there are between 80 and 100 million people who fall into the vulnerable category. Now, maybe I should have expected that, but that's between 25 and 30% of the entire population. And that presents a daunting task in getting those people protected early on. She was pretty optimistic about how quickly we might actually be able to get those 80 to 100 million people inoculated. But in order to do it, she thinks we need to have up to 4 vaccines, not just the 2 that have been approved so far. And they've got to spread those out. The total number of doses required to be produced is obviously staggering. And she said, maybe we could do it by April. And I just did the simple arithmetic, and I was thinking, no way in the world is it going to happen that fast. But we'll see. They're hoping for it. The 2 vaccines that have been mentioned as in the pipeline, more or less, I think are both 1-dose vaccines. I don't think anybody had a good guess as to how long it might be before those are actually made available in substantial numbers. Another thing was that the governors are responsible for the allocations within each of their states, and I was wondering whether Governor Northam's intention is to defer to the group that Norm mentioned, MAC, which I guess is the committee. I'm not sure exactly what the acronym is for, what the words are for, but is the governor actually going to defer completely to that committee in order to make set the priorities?
Okay, so thanks for that comment about the vulnerable populations. I think I mentioned this in answering someone else's question earlier. Stacy, I believe, the vulnerable population in Virginia is somewhere around between 1.5 to 2 million, using that same sort of 20% guesstimation. So it's a large group of people, and you're correct about that. And it will be helpful to have more than just the Pfizer and Moderna vaccines to be able to reach that population. The VDMAC, that stands for the Virginia Disaster Medical Advisory Council. In our unified command, we established the VDMAC to help us develop guidelines and guidance for dealing with two big issues. One was around the hospital surge that we were expecting in the spring. We wanted to provide the hospital and healthcare systems with guidelines for how to, if they were in a crisis situation where there weren't enough beds or weren't enough ventilators or that sort of thing, how they would allocate those resources, right?
Yeah.
We are utilizing them in a similar way with respect to vaccines, because we know that initially the vaccine will be a scarce resource and we need to allocate it in an equitable and ethical fashion. And we're asking for their advice. But as their name indicates, they're an advisory council. They're part of the Unified Command. They provide advice to me as the state health commissioner, to the secretary of HHR, and to the governor. And the decision to do about how we're going to do this will be so Governor, to answer your question, then Governor Northam could say, well, thanks for the advice, but I think we also need to do X, Y, and Z.
Yeah. Another observation, in today's Washington Post, there's a front page article about the Board of Supervisors in Campbell County. And I'm sure Campbell must be in South or Southwest Virginia, that actually passed an ordinance defying the governor, completely defying. We will not follow any of the recommendations. Well, okay. I mean, I get it. It's a political issue, and some people are more inclined to be defying than they are to think about the health of their neighbors. But what worries me is that to the extent that that kind of behavior occurs in Virginia, and we're allocating resources by population, and these people don't care, I don't want to waste resources, and have vaccines sent off to a jurisdiction wherever in the state that isn't going to use them. How are we dealing with that? I mean, I realize it's a moral issue as well as a political and logistical issue, but I hate the thought of wasting resources.
Campbell County came up yesterday in the governor's news briefing. He made the point that we were going to ensure that the steps that needed to be taken to fight this virus were going to happen across the entire Commonwealth, and that's what we're going to do. There was in Bedford, there was a similar thing that happened. Board of Supervisors just blatantly disregarding the executive orders, and we cited them for that. I mean, it's all going to be a lot of political, like you said, political drama, and I think it's important to separate out what's happening at the Board of Supervisor level and what's happening on the ground. Because the Board of Supervisors is doing that, I don't think that's a reason for us to do anything other than our utmost to protect the residents of Campbell County and all the other counties. So we'll do what we can to convince the residents to do the right thing, and we'll vaccinate them as well. Now it's voluntary, and we're going to have, it's a big communication campaign to convince them to do it, but we'll do our best.
Different question again. There's been discussion, but I don't know any resolution about how long the preventative qualities of these separate vaccines will protect people. Is it something that we're going to have to do every 6 months, every year, every however long? Do you have any information, insight into what's likely to be the duration of these things when they come up? And will there be significant differences, do you think?
The short answer is we don't know.
No.
And that's one of these, the fact that we don't know that is one of the other reasons why I say that some of the individual behaviors that we're doing now should continue through the vaccination campaign. You know, I myself, I'm going to continue wearing the mask and washing my hands and staying away from folks.
Well, last question at the moment, anyway. The U.S. military is going to be involved supposedly in the logistics of all this, of literally getting vaccines and perhaps other equipment too that needs to still be in greater supply into the various locations. How is that being coordinated through you and the department and any other agencies in Virginia?
Operation Warp Speed is the logistical side of that is being headed up by General Perna. We've already had meetings, a couple of them with General Perna about getting the vaccine that's allocated to Virginia here, sites it's going to go to and so on. And we'll continue to work with them going forward.
Do you expect, for example, to use military transportation equipment to haul these things away from wherever they might be initially delivered into the Commonwealth?
No, it's going to come to us centrally, and then we are in charge with the further distribution.
I got you. Okay.
All righty, Jim. I'm going to move on to Linda, and if you have something else, we'll come back.
Yep.
Linda, it is your turn.
Sure.
Hi, we're glad to see you.
Good to see you. Good morning, Commissioner Oliver, and again, thank you and the VDH team for the tremendous work that you're doing. I just have a quick question. The documentation of the administration of the vaccine, will that be documented in the state immunization registry or a CDC registry? And if so, where is documented? Will all practitioners be able to see that their patient has had the vaccine? Because I think that will help as they're seeing their patients, that they can remind them that they either need a second dose or when it's widely available to get it.
So all the vaccines that are administered will be in the immunization registry, the VIS. And all providers of the vaccine have to be registered with the VIS, which will mean that once you vaccinated someone, you'll know when they got it, or actually if they got it someplace else, you'll even be able to see that. And then you'll be able to see when they need the second dose if they're on one of those 2-dose vaccines. We are also tracking, the VIS will be connected to the CDC's system. I can't remember what the acronym stands for now. It's VMAS, or VAMS rather, VAMS. And that's because the CDC wants to be able to do the same thing, track how the vaccine is, ensuring that the vaccine is getting out and that the people who get it are being followed up and receive the second dose, for example.
So
it'll be in both of it'll be in both of this and in the VAMS.
Okay. So, but only you can only see it if you actually administered the vaccine, not if you're already a registered, provider of the state immunization registry.
Now you should be, if you're a provider who's in this, you ought to be able to see anybody in the VIS.
Right.
Right. So, someone shows up in your clinic, you can look up and see whether or not they've gotten that vaccine.
Thank you.
Mm-hmm.
Dr. Oliver, I think since no one else has asked to ask a question, I will ask mine now. From my perspective, the lack of a national coordinated messaging campaign has hurt us all. It's been difficult, I think, for people to understand day to day what they are personally supposed to do besides wash their hands, when to wear a mask, when not to wear a mask, what gathering is okay, what gathering is not okay. Are you aware of any plans for such a national campaign as we move forward? Where I see a lot of confusion still is, well, of course I wear my mask inside if I'm fewer than 10 feet apart, but do I wear my mask outside? Do I wear my mask when I take a walk? And I think it is, again, it is that lack of a national coordinated message that has caused a lot of our current difficulty. And where do you think that might go?
Well, I would agree with you that that has been a major, a lack of a national coordinated response around the pandemic has been a huge problem. And it's been left up to the states, state by state, to figure that out. I would hope that with the new administration that this will change, and we'll see with the task force that's been put together whether or not we get a little more consistent direction, and in addition to direction, more resources to help. I mean, like the vaccination campaign is a good example. We have a bunch of money right now, but it's all to be spent by December 30th, right? And as we were just saying, the bulk of the vaccination campaign is going to occur after that. And we need resources to do it. So I'm hopeful. I think that we will get the resources, and I'm also hopeful that we'll get better direction on how to fight the pandemic from our federal colleagues. So we'll wait and see.
We'll wait and see. I will tell you that localities are also struggling to make the best use of that CARES money because of the timeline. It makes it very difficult for us to use it as wisely as we might.
Okay. Yeah.
Hey, this is
Any-
I think Jim wanted to say something.
Jim Schuler, you go, buddy.
Thank you. I just couldn't get into your chat queue.
Sorry.
Dr. Oliver, of course, pending FDA approval, have any vaccines been distributed to individual states and stockpiled at this point in time, since time is of essence? Is there a stockpile now in Virginia waiting to be distributed once the FDA has made an approval?
No. What we've done, since we knew that the Pfizer vaccine was probably going to be the first one that would get distributed, we identified ahead of time 25 sites that have the ultra cold storage capability, and they're distributed adequately across the Commonwealth. So we pre-positioned them in that way. Pfizer says that within 48 hours of getting their EUA, they will begin distribution of the vaccine. So we could start seeing vaccine as early as next week, and it will come rapidly. The first tranche of vaccines will be a small number, but they are prepared to ramp up production fairly quickly.
Thank you.
Mm-hmm.
All right. Is there anyone else who has questions for Dr. Oliver? Going. Norm, thank you so much for your time and your patience with us.
Thank you. This is all really important stuff, and I'd like to thank you and the board for your important work in trying to deal with all the regulatory stuff, but also providing support and advocacy for the work of the department. We appreciate that as well.
Thank you. All righty, on we go. Since we already took our break, Dr. Jing, Anna, we will go directly to you and your presentation on wastewater monitoring for COVID. I think. Anna? There you are.
Hello, before the presentation, I want to make sure my panel members are available. Is Kyle there?
Yes, I am. Hi, Dr. Jung.
Yeah, and also Dr. Dagan's there?
Yes, I am. Thank you.
Right, so I think we can start at our presentation then. Well, so Madam Chair and members of the board and Commissioner Oliver, thank you for the opportunity to give a presentation on wastewater surveillance for COVID-19. And I have invited two colleagues of mine from Hampton Roads, San Antonio District and VDH to join me in deliver this presentation. So next slide, please. So the wastewater monitoring and surveillance has been successful using to tracking chemical and biological markers of human activity. So how does it work for COVID-19? So genomic material from the SARS-CoV-2 virus is shared in the faces of affected people. And this genomic material can be detected and measured in wastewater. So such data can be used to better understand the COVID-19 spread in the community. And fundamentally, the data can be used to determine the prevalence of infections in an entire sewage neighborhoods or facilities. So in the past summer, a group of people who are interested in this topic and understand the potential benefits of used wastewater surveillance formed a Hampton Roads Wastewater Surveillance Working Group. So currently, this group consists of more than 15 members from Hampton Roads Sanitation District, Public Utilities, and Virginia Department of Health, and academia such as Old Dominion University. So the group provide a platform, for collaboration, which is really critical for, utilize the wastewater data to its full potential, and providing strategies for implementation of wastewater surveillance, providing technical support and recommendations. And finally, is public communication for better understanding of wastewater surveillance. The members of the working group meet virtually, once in every couple months. Second slide. You want to go to previous slide. Sorry about that. So in the beginning of this pandemic, HRSD already started monitor the viral loads in the wastewater. So I invited my colleague, from HRSD to give a presentation. And Kyle Kirst is an environmental scientist of Hampton Roads of San Antonio District, will present some work conducted by HRSD. Kyle, can you take away?
Sure. Thank you. Can we have next slide, please? So I'm going to just a brief overview of what we've been up to since March, which is our SARS-CoV-2 surveillance in wastewater. So just really brief orientation. This map has the sewer sheds, so the catchment areas for the 9 treatment facilities that we've studied and that we've been monitoring since March. We have smaller facilities which we haven't done routine monitoring on, so I want to focus on these. When you see data, it represents this region. And so just kind of a quick note, back in February when we were considering doing this work, we realized that we were in a really good position. One, we have access to and understanding of the treatment plants and the catchment areas and all that, but we also have a pathogen lab that has been enumerating viruses in a variety of matrices, including wastewater, for the past 5 years. And so we realized that we could likely make this work and potentially generate some useful data. And so our overall goal, kind of stated on the slide, is just to get this regional wastewater surveillance, for the SARS-CoV-2 virus up and going, and see if we could characterize the rise and fall of COVID-19 cases in this community by surveilling our wastewater. Kind of instrumental to that, we have specific objectives. One, we just have to actually make the assays work. So we'd be able to detect SARS-CoV-2 in wastewater. We've been running the CDC panel, so the N1, N2, and N3 assays. Beyond that, we need to have sensitive enough, we need to have assays with the appropriate sensitivity, so levels of detection to describe trends, not just across the region, but within specific treatment plants. So we need to be able to describe the sort of rise and fall and changes in viral load at our facilities. And then finally, if that's working, we want to test the idea that wastewater can act as a leading indicator of new clinical cases. And so that's our broad goals for this work. And I just want to show you some of the data we've been generating. So next slide, please. So one of the challenges, and I'll describe this figure, which has a lot of pieces, but one of the challenges we have is, as we started generating wastewater data, we realized that our catchment boundaries, so the boundaries that describe, the area that one of those treatment plants services, don't nicely overlap with city or county boundaries. And so, one of the things we want to do is compare the signal in wastewater, so the RNA that we detect in the wastewater using the CDC panel, to clinical cases. And so the way that we decided to try to do that was at the regional level. And so this figure, if there's any way to sum up lots of data and lots of work, this figure might be it. What we have is, so on the primary y-axis on the left, new clinical cases by date. So these are PCR positives that we take right off of VDH's data repository. And those are represented by the gray bars kind of going across there, and also by that darker blue trend line, the lower of the two trend lines. On the right, on the secondary y-axis, we have viral load. So what this is the concentration of one of our assays. The N2 assay was the best performing for us, so we focused on that. Scaled up by the treatment plant flow at the time of collection, and then all 9 of those for the major facilities in the Hampton Roads region are aggregated to say, okay, this is the regional viral load, at least for the population serviced by our 9 major plants, which is the majority of the Southeast Virginia kind of Hampton Roads population. And so those data are represented by the black dots connected by that dashed line, and also by that lighter trend line with going along the x-axis are the community interventions that Dr. Oliver already described in really good detail. So I just put those on there as kind of a reference point for when you see changes in the trend, trend changes, whether it's clinical cases or viral load, what was going on in terms of reopening and things like that. And so if you look at the two signals, one thing we find is that they do show really good agreement, right? Changes in one, whether it's an uptick or kind of a downslope, do correspond to changes in the other. One thing to note here is you can see a very large peak in July, really beginning in June and peaking in late July, which I know we're all aware of, but I just want to point out a couple things about it. One, just the magnitude of it created this stretching of the range of the graph, and it kind of has flattened out the first peak we saw, which actually was visible back in April, but now kind of looks like noise in early data, but we were actually able to see an early peak then. It's just hard to notice now because of this really tall peak we saw in July. The other thing to point out here is we do get kind of we get some indication that the wastewater signal might lead, the trends in the wastewater signal might lead trends that we're going to see in clinical cases. And so before we get off this figure, I would want to point out, if you just focus on June and see the wastewater signal, which is, the black dots and dashes again, do seem to ramp up before we see the corresponding spike in those gray boxes, or the gray bars, which are the clinical cases. I think we see a similar thing on the downsloping side. So basically August on of this large peak, which gave us an indication, which we eventually test statistically, that wastewater might give us an early sort of idea of an upcoming trend. We go next slide, please. And so these data, hopefully this is coming clear for everybody, really lend themselves to a spatial kind of look. So what we've done is boundaries. We read those in, and we apply the viral load that we get each week of monitoring to each of those boundaries, and then just kind of plot that on a heat map. So cooler colors here would indicate lower viral loads at that treatment facility serviced by that area on the map. And of course, red indicates, a greater intensity. So in this case, a greater viral load. We don't have any clinical data on here because of the issue I mentioned earlier with the boundaries and getting the data to align. But if you look at the 4-panel portion of this on your left, I've pulled out some dates that are kind of indicative of the different portions of the SARS-CoV-2 progression through our area since March. And so that upper left one is actually our very first sample date. And what you can see is, we had detections at a few plants, but overall viral loads are very low. By contrast, if you fast forward to late July, you can see this was our largest, kind of our hottest day that we monitored in terms of viral load, high concentrations at numerous facilities. And then the other two are September and then on to later October, where we saw a decline and then a ramping back up. The box that's kind of blown up on the right, the larger map, is almost our most recent data. We've continued to collect weekly since March. It's been an unbroken sort of chain of data that we've got, which makes it really useful. This is from November 17th, and you can see just based on the colors, even if the scale is hard to see at the bottom, that we are kind of seeing this upward trend, what will likely be described as like a third wave of sort of impact for our area. Could you flip forward one, please? And so here, this is kind of an interesting, maybe innovative way to take all of the data we have and look at it at once. So if you can imagine, there's been a number of weeks. I mentioned we've sampled every week since March 11th. If you were to plot each of those on a map, the boxes, you'd have so many boxes, it'd be very difficult to look at. But using the software I use, you can kind of stitch them all together, almost like a flip book. And what you get is the same unit, so viral load at the wastewater facility. Each of the areas on the map is, again, the catchment for that, treatment plant. And viral load, again, just on a heat map kind of scale. And this really is, in terms of viral load, at least for the wastewater treatment facilities, what the progression looks like through our region. So you can see localized areas getting, the effect. You can see the effect of localized outbreaks, which we've been able to track back to outbreak recorded data that VDH documents. So this is kind of another potentially useful way to look at trends through the area and demonstrate how useful the wastewater data can be as a complement to the clinical data. Next slide, please. And so there's been a lot of analysis and even spin-off studies from this. So there's quite a few findings, but the general ones we can pull out just for today are that, one, we were able to detect viral RNA in our first sample. So not at every facility, but I think at least 2 had positive detections before we actually saw a clinical positive in the region. And now we know that there's some bias there towards just the effect of getting clinical testing widely up and going. But this is potentially a benefit of the wastewater testing, because you just have the ability in one shot to sort of test an entire community. And so we like that as a finding. We think that really shows what this is. Like I mentioned on the last slide, we are able to see localized outbreaks as well as regional trends. So you can get a smaller scale look at what's going on, and you can also compare to the clinical data at a regional scale, both of which, you know, have utility, we think. And then finally, to kind of test that third hypothesis, we ran some cross-correlation analysis comparing the wastewater signal to the clinical signal, and we do see a strong and significant association there with that 1 week lag, meaning that wastewater likely does give some indication of upcoming trends in the clinical data by approximately a week. And so that's just where I'm going to stop. I don't want to take too much time because we have another presenter. Thank you for the time today.
Okay, next slide, please. Good morning, and thank you for this opportunity to talk with you about a new project that is kicking off here at VDH. The CDC has created the COVID-19 National Wastewater Surveillance System, which is an effort to gather data from wastewater surveillance through a new data portal. VDH has received funding to participate in this project using the ELC funding under the category of emerging issues. So as Kyle was discussing and Dr. Jang, wastewater surveillance for COVID-19 can be a powerful tool because it's picking up both the asymptomatic as well as the symptomatic individuals. And it's also more real time. In other words, we're getting that sample tested today. It's not waiting for someone to develop symptoms to get tested. So this data can be used then to be able to evaluate trends of the disease prevalence in the community, and that's both increasing and decreasing trends. And as such, it might be useful to assess how well our measures are using, the measures that we're taking, how effective are they in curbing the virus. And as the HRSD data shows, the wastewater surveillance tracks really well with the various phased openings. So it also has been used for early detection and isolation of infected persons on college campuses and has helped prevent some widespread transmission. Next slide, please. So the National Wastewater Surveillance System, or NEWS, is a new tool that complements the existing COVID-19 surveillance system. It's a collaboration between CDC, Health and Human Services, utilities, laboratories, and various state and local stakeholders, with the goal of gathering that wastewater surveillance data from the various communities into one spot, and that would be CDC. Now, the data request from CDC is pretty extensive. It requires that the labs provide details of their analysis, a lot of their bench data, and that the utilities are going to provide details on the sample itself and the sewer shed that it represents. So in this slide, the process involves collection of routine samples of the raw influent wastewater. Those samples are analyzed in various laboratories. The lab and the wastewater plant then provide, or utilities provide those details on the sample to VDH and other health departments. VDH then inputs the data into the CDC portal. At CDC, the data will be analyzed and it's going to be used to look at trends in the virus's prevalence in the community. VDH is also going to collaborate with CDC to be able to compare clinical cases to the predictions from the sewer shed data. VDH will have access to the data for any additional analysis, visualizations, dashboards, and we can participate in data sharing from other states also through CDC. And obviously, all data sharing will follow strict guidelines to ensure patient confidentiality. Over time, the goal is that the data in NEWS will help public health officials and other stakeholders better understand the extent of COVID-19 infections in communities and perhaps learn lessons that can be applied in the future to other diseases. Again, this whole NEWS system is intended to complement existing COVID-19 surveillance systems and not replace. Next slide. So this project that VDH is participating in is, CDC calls it their early adopters. Virginia is one of 8 states that was selected for this early adoption program. And one of the reasons I think that that we were selected is because we do have a fair amount of surveillance going on in the state already. And also forgot to say, so we received $300,000 in this award, and that money is primarily to be able to hire staff to implement the program. Next slide. So I mentioned that we have a fair amount of surveillance going on. There's about 24, 25 separate locations that we know of that are doing this type of surveillance pretty much on their own. They are not receiving state funding for it. They're either doing it, utilities have been initiating this on their own, like HRSD, or in some cases, some local governments have initiated some. So because of this already kind of large interest in surveillance in Virginia, and also because of HRSD's work in this field, you know, Kyle didn't mention it, but HRSD has become one of the leading researchers on wastewater surveillance for COVID-19 and are recognized actually not just nationally, but globally as experts on the topic. So that also likely helped put Virginia on the list. Next slide, please. Okay, so my slide is not showing up quite properly, so let me tell you what this means. So our project has 3 goals, and the first goal is obviously to collect that data, that surveillance data, while we ensure that the data is reliable, that's actionable, and that we have very high quality data. And that data is centralized at CDC using the News Decipher platform. The second is to analyze the surveillance data and convert it into forms that are useful and inform the epidemiologic and programmatic decisions related to SARS-CoV-2 infection. And then the last goal is to support a community of practice by facilitating collaboration and exchange of information among stakeholders, both within the state and within this group of 8 early adopters. So this includes sharing best practices, lessons learned, and troubleshooting, as well as fostering new research. Next slide. So the status of the project at VDH is that the $300,000 has been awarded. We have submitted our work plan and budget to CDC, but that has not yet been approved. We have gone ahead and interviewed staff, and we've completed those interviews, and so we are waiting on that approval of that budget. Slide. So this is an ambitious project, and of course there are barriers to successful implementation. First is funding for the actual sample collection and analysis. As I mentioned, to date, the utilities have primarily been funding the sample collection and analytical costs. And also the data request from CDC is lengthy and comprehensive. So it's going to take a lot of time on the part of those that are participating, especially the utilities and the labs, for them to be able to provide all the necessary data. So we're going to have to convince them that it is a worthwhile project. The third thing is that the data has to be timely. The CDC is looking for the data to be uploaded to the portal within 48 to 72 hours of sample collection. That's really a really quick turnaround. So, but obviously, you know, that timeliness is critical if the CDC is going to use this to track trends nationally. And the last thing is that in order for some of the type of analytics to occur, the utilities have to share the geographical extent of their sewer shed. A lot of utilities are rather protective of this information, and some have been reluctant to provide that. So again, it'll be a matter of trying to work with them to see if we can figure out a safe way to share that data. Now, I have an asterisk on the funding. And that is because just before Thanksgiving, CDC announced a short-term funding to cover the cost of analysis, shipping, and materials, and the utilities have to apply for acceptance into this project. This project involves twice weekly sampling with a phase 1 period of 6 weeks and the potential to extend an additional 9 weeks. We've notified all of our utilities. A number of them have already applied for this assistance. So that is good news. And with that, I will thank you for your attention, and I'll pass it back to Dr. Jang.
Okay, I'm going to, next slide, please. I'm going to give it a brief summary and also provide some take-home message. So based on a cost analysis, wastewater surveillance is the way to go because it allows us to screen a large number of people with a single sample. As Carl mentioned, and the wastewater surveillance can provide early warning. And for COVID-19, evidence suggests that it can provide about 5 to 7 days lead time on change in the prevalence. And so, as Dr. Duggins mentioned, that CDC is intending to establish a national wastewater surveillance systems. We believe that this portal has the potential to be a robust tool for evaluating trends statewide and nationally. And also the systems can be retrofitted to locate or monitor hotspots. Wastewater surveillance is a complementary tool to the clinical testing. It's not meant to replace. So finally, if this CDC National Wastewater Surveillance System is established, we believe that the systems could be used for other disease surveillance, such like opiates, in the future. So thank you for your attention. And did you have any question for the panel members?
All right. Thank you, Dr. Jang. Thank you, colleagues. Are there any questions for Dr. Jang or her colleagues? Anna, that was really wonderful. Thank you so much. I feel like I as a local elected official who deals with wastewater issues all the time, I just left a whole new perspective to what we do. Thank you very much. All right, folks, we're gonna, I think, to move through Mr. Hilbert's update on regulatory action before we take a little bit of a lunch break.
Thank you, Madam Chair and members of the board. So the regulatory action update for today is up on the screen. There are 28 pending regulatory actions under development. You can see how they're distributed among NORA's proposed actions, final actions, fast tracks, and emergency/NORA actions. You also have been provided with a spreadsheet that provides more detail on each of these pending actions. Since the last meeting, the commissioner has approved 2 regulatory actions on the board's behalf, and they're summarized here for your information. First was the commissioner approved a notice of intended regulatory action pertaining to the certification of community health workers. During the last General Assembly session, House Bill 688 was passed mandating that the board adopt regulations that set forth the requirements for the use of, quote, a community health worker, as well as requirements for training and education necessary to meet the requirements for the certification of a community health worker. So that NORA was approved on the board's behalf by the commissioner. And the other action that was taken was to withdraw a final action that had been pending pertaining to the regulations governing vital records. This action had been started some time ago following a periodic review of those regulations. The purpose of this action had been to allow for an administrative process to change the gender on a birth certificate of a person who is transgender. And due to legislation that was passed by the 2020 General Assembly session, this regulatory action is actually no longer necessary because in the last session, two bills were passed, House Bill 1041 and Senate Bill 657, passed and signed by the governor to do the same thing as this regulatory action, to allow an administrative process to change the gender on the birth certificate of an individual who's transgender. So this, the General Assembly has taken care of this through a change in the code. We do no longer need to pursue this particular regulatory action. Go on to the next slide. Yeah, so periodic reviews, again, we're required to review all of our regulations at least once every 4 years to determine if those regulations can be kept as is, or if they need to be amended in some way, or if they should be repealed entirely. We currently have 13 different periodic reviews in progress. They're listed here on the page. And then if we can go to the next page. And also, as we always do, we've summarized for you the executive branch review activity that has been completed since the last board meeting. So you have there the actions that have been taken by the Attorney General, the Department of Planning and Budget, the Secretary of Health and Human Resources, and the Governor's Office, all actions taken on regulatory actions previously sent forth by the board. So Madam Chair, if there are no questions, that completes my update.
All right. Do we have any questions for Mr. Hilbert? So I do want to say that when Benita and Tommy and I all came on at the same time, I believe the very first regulatory action that came before us besides abortion clinics was the repackaging of crab meat. So we're on it. We're on it again. We cut a broad swath. So if it's okay with everybody, let's take about 30 minutes now for a little break. Let's everybody do what they need to do, grab something to eat. We'll be back here about 12:25 and group for our regulatory action items. Is that okay with everybody?
Madam Chair, we
Yes,
still
sir.
have to do the public comment period.
Oh, I'm sorry, Joe. I totally missed that. Do we have anybody that we know of?
We do not have any. We do not have anyone signed up for public comment.
Okay. So, and through this forum, would we also know if there's somebody here who has not signed up?
We don't have, I'm sorry, we did have one person signed up, but she's
Okay.
no longer in the meeting. So why don't we just revisit that when we come back from lunch?
Okay.
And make
Fair
double
enough.
sure that
Fair
there's
enough.
no one there.
All right.
Okay.
That sounds good. All right. See you at 12:25. Thank you. And Linda was with us too when we first came. I don't want to leave Linda out. All right. Thanks. All right, is everyone back?
We're back.
All right, hello.
We're back.
I'm happy to see you. Well, I think it is time to move on to our regulatory action items, and we start with Dwayne Roadcap talking about
Madam
water.
Chair?
Yes, sir.
For the public comment period, I just wanted
Oh.
to, for the record, we do not have anyone signed up to speak today.
Well, for the record, I don't mean to keep forgetting public comment period. So thank you for that. If our person does come back, we certainly are willing to make accommodations. So thank you. All righty, so now we can move on to our first regulatory action item. And Dwayne Roadcap.
Hi, can you hear me, Madam Chair?
We certainly can.
Thank you. I'm Dwayne Roadcap. I'm with the Office of Drinking Water, and I'm going to present to the board today the amendments, the final amendments to the Virginia Water Works regulations. So I'd like to thank the board for considering this today. And I'd also like to add that we have Nelson Daniel and Bob Edelman available to answer questions. They work with the drinking water program and have been the most involved in working with the stakeholders over the past few years to get these regulations to you today. So a waterworks is defined as serving 25 people 60 days out of the year. So this can be any type of water system that serves a daycare, a gas station, or a restaurant in a rural county, up to several hundred thousands of people in our large metropolitan areas like Fairfax, Richmond, Newport News, Virginia Beach areas. We regulate about 2,810 public water systems or waterworks in Virginia. That represents about 89% of the Commonwealth's population. So our public water systems, waterworks in Virginia serve about 7.5 million people of Virginians. Our staff performs sanitary surveys and inspections of the public water systems. We have engineers who provide technical assistance and provide training. We also issue permits and do the plan review designs for any upgrades to the public water systems. And we track compliance, manage the data, look at the sampling that's done for the public water systems. And where appropriate, we will take enforcement action. And we also offer low interest loans to help with construction and aging infrastructure at the public water systems. So we do a lot to help our public water systems stay running properly, especially during this pandemic. It's been really important. Another thing that our staff does is we assess vulnerabilities for man-made and natural disasters. So we have an emergency response team that focuses in that area as well. The drinking water program is based on federal law and regulations, the Safe Drinking Water Act. And so Virginia has primacy as long as we provide regulations that are at least as stringent as the federal requirements. So one of the things that you'll note with these regulations is that we had the U.S. Environmental Protection Agency review these regulations before they came to you today, so that we made sure that the EPA was happy and would maintain primacy for Virginia. The regulations are organized into 3 parts. Part 1 deals with the administrative pieces of the regulations, dealing with permitting and appeals and variances and how that process works. Part 2 describes how we operate the systems and do the sampling. It's the monitoring and reporting requirements, and that's primarily what the EPA would be looking at is in Part 2, because that's where the meat of the federal requirements are housed. And then Part 3 talks about the design and the construction of a waterworks in Virginia and how you would properly design and construct a waterworks. So the board approved proposed amendments to the regulations about 2 years ago in December 2018. And since that time, we completed an executive branch review, and then they went through a public comment period, a 60-day public comment period, which ended in January of 2020. So earlier this year, we concluded a 60-day comment period. We received 77 comments from that public comment period, and our staff worked with the Waterworks Advisory Committee, which comprises of about 15 to 20 stakeholder groups in Virginia, and we went through all of those comments and made some edits and updates, which are in front of you today. I will say that the stakeholder community is very supportive of these final amendments because they primarily simplified text, improve the readability, they're better organized, outdated requirements are gone, and it allows for present day technology and improved definitions. So the final amendments are substantially similar to the proposed amendments that the board considered 2 years ago. So of those 77 comments, there were two primary categories that people were commenting on. One was cross-connection control, and the other was fire hydrants. So cross-connection control talks about the risks of backflow into the water system. And a quick example for you might be someone installing a lawn irrigation system. So they can add chemicals to that lawn irrigation system. We don't want those chemicals backfeeding into the public water supply. Another example might be at a restaurant where you have a dishwasher. We don't want that dish soap and the dirty water backfeeding into the public water supply. So that's what cross-connection control deals with generally. For the fire hydrants, it was about risks of freezing of the fire hydrant in cold weather. And I don't want to dive too deep into the details, but basically there's a weep hole on fire hydrants, and stakeholders did not want us to plug that weep hole, because if you plug the weep hole, then there was a risk of the fire hydrant freezing. The reason you would want to potentially plug that weep hole is, again, to help prevent backfeeding into the drinking water supply. So the final amendments on these two topics, we went with the stakeholder comments about not plugging the weep hole. And then for the cross-connection control, we didn't get a lot of stakeholder unity and thought on that topic. And so what we tried to do was move from a prescription-based regulation to a performance-based regulation. And that seems to have satisfied the stakeholder community that has disagreement in this area. The disagreement primarily runs around the topic of how much staff would somebody have to hire to do the proper documentation and tracking for the cross-connection control plan. And so by moving towards the performance requirements and moving away from the prescription, that allowed for people to have different ways of dealing with that tracking and reporting. And so we think that we found a good answer that satisfies stakeholders generally, even though they disagree on what that should look like. The EPA also provided us some significant feedback on the regulations, but ultimately agreed that they are at least as stringent as the federal requirements, and we've made several edits that EPA requested in these final amendments. So ultimately, we're requesting that the Board of Health approve these final amendments to the Waterworks regulations. If the board approves the final amendments today, then another executive branch review occurs. And then upon the executive branch review and approval, then the final regulations would be published for a 30-day notice period to the public. And then finally, I will say that I received a couple of questions about, do we expect any EPA actions to have any effect on the final amendments to the Board of Health regulations? We don't expect any EPA actions between now and January the 20th that will have any impact on the Waterworks regulations or the federal requirements. There are two things that the federal government is pursuing right now. One is dealing with the lead and copper rule, and we're expecting that to happen within in the near term. And once the lead and copper rule revisions happen, then the agency would have up to 2 years to adopt those federal requirements. And then the other category that the EPA is looking at is regulation of per and polyfluoroalkyl compounds, or PFAS. And there's a couple of bills that the General Assembly considered in 2020. And so we're on track to deal with the PFAS category as well. But again, we don't think that there would be anything going on at the federal level that would impact what we're doing here today. So with that, I'll pause and thank you.
Sorry, I had to unmute. Thank you very much. Do we have any questions? None at all? Okay. Well, with that, I will entertain a motion, please.
This is Linda. I move to approve the final regulations.
Okay, so we have a motion from Linda Hines. Do we have a second?
I second.
Is that you, Anna? Okay.
Yes.
So we have a motion from Linda and a second from Anna Jang. Motion and a second on the floor. Is there any questions or conversation? All right, seeing none, I will call for the roll call.
Thank you. Mr. Kreitzer?
Yes.
Thank you. Mr. East?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison?
Yes.
Thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritt?
Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Schwartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. Ms. Whipple?
Yes.
Thank you. Madam Chair, the motion has 4 ayes. Or I'm sorry, 15 ayes.
Okay, I was a little confused there, but 4 plus 11. All right, thank you very much. All right.
Hey, this is Jim. May I ask a question that of Mr. Roadcap that certainly won't affect the vote? I'm just curious.
Sure.
Well, one is, how many episodes or incidents of problems with waterworks around the Commonwealth have been encountered over the last year or two? I mean, is this something where there's a sort of a chronic set of problems, or is it really rare for problems to arise?
So that's a great question. During the COVID pandemic, we've been monitoring waterworks very closely, and we've had a couple of episodes of which I'm personally aware of where the waterworks had to take some internal actions to deal with some COVID outbreaks among the operator staff. Generally, getting to your question about chronic problems, this would go towards the topic of aging infrastructure. We've got a lot of old infrastructure under the ground. The EPA estimates that in Virginia we have an $8.1 billion estimated problem over the next 20 years. And so that's where our loan program and our construction loan program tries to address that problem. But there is a funding need in that aging infrastructure category. Thank you.
One more question. Again, certainly not affecting the ultimate results, and maybe this one goes to Joe as much as it does to Mr. Roadcap. The process of getting these regs in place, if I read the various materials correctly, was like 6 years. Aren't we supposed to redo these things, or examine them again every 4 years? And what kind of a problem does that pose, if any?
So that's another great question. Thank you. The periodic review for these regulations happened this year. So this action by the board today will cover the periodic review for the waterworks regulations today. They're reviewed every 4 years. So the next review would be in 2024. We're not really expecting any issues with the periodic review and what we're doing here today.
All right. Thank you very much. All righty, if we can move on to regulations for adult comprehensive sickle cell clinic network. And that's Ms. Board.
Yes. Good afternoon, Chair and members of the board. I'm Heather Board. I am the Acting Director of the Office of Family Health Services. And I'm here to first speak with you about the Adult Comprehensive Sickle Cell Clinic Network regulations. I would like to share that Available for additional questions are Marcus Allen and Shamari Cromarty, who are also on the call. So thank you very much for this opportunity to present our proposed amendments to 12 VAC 5-191, the State Plan for Children with Special Healthcare Needs Program. And our goal to adopt regulations for the implementation of an adult comprehensive sickle cell network. Section 32.1-68 of the Code of Virginia requires the Board of Health to adopt regulations to implement a pediatric and adult comprehensive sickle cell clinic network. Regulations for implementing a pediatric comprehensive sickle cell clinic network are already established in 12 VAC 5-191-310 and 12 VAC 5-191-320. This regulatory action establishes regulations for implementing an adult comprehensive sickle cell clinic network that mostly mirrors the pediatric regulations. 12 VAC 5-191, the state plan for the CSHCN program, is a regulation governing several programs serving individuals with special healthcare needs administered by the Department of Health. These programs include the Care Connection for Children Network, the Child Development Services Network, the Virginia Bleeding Disorders Program, Genetics and Newborn Screening Services, Virginia Congenital Anomalies Reporting and Education System, Virginia Sickle Cell Awareness Program, and the Pediatric Comprehensive Sickle Cell Clinic Network. The Adult Comprehensive Sickle Cell Clinic Network will mirror the existing Pediatric Comprehensive Sickle Cell Clinic Network. Once implemented, it will be a statewide group of clinics and subspecialty providers that provide comprehensive medical and support services that are collaborative, family-centered, culturally competent, community-based, and outcome-oriented for individuals age 18 and older living with sickle cell disease. The overall purpose of the Adult Comprehensive Sickle Cell Clinic Network is to improve the coordination of care and transition of young adults with sickle cell from pediatric to adult medical care. The rationale for implementing an adult comprehensive sickle cell clinic network include increased sickle cell related mortality that's been shown in 18 to 30-year-olds with the highest rate of acute care encounters and rehospitalizations in this group compared to the older group of patients who would be expected to have increased illness and complications due to advancing age. According to VDH data, the rate of emergency department visits for sickle cell disease in Virginia was highest among the 18 to 30-year-old age group at 53.8 emergency department visits per 10,000 visits and 53.1 ED visits per 10,000 ED visits in 2018 and 2019, respectively. Though pediatric care and medical advances have increased life expectancy for persons with sickle cell, healthcare delivery systems, and public health initiatives supporting the optimal transfer from pediatric to adult care have not kept pace with the growing adult population. Virginia only has one comprehensive adult sickle cell center located at Virginia Commonwealth University. Benefits of having a network would include short-term measurable outcome, being the establishment of a regional network that will provide continuity of services and treatment for the adult population living with sickle cell disease. Long-term measurable outcomes include an increase in the number of adults who continue into specialty care and establish a medical home with a specialty care provider, a reduction in the rate of ED visits for adults with sickle cell in the 18 to 30-year-old age group that contributes to improved health outcomes. The current regulatory provisions for the Virginia Sickle Cell Awareness Program and the Pediatric Comprehensive Sickle Cell Clinic Network are contained in the state plan for the Children with Special Healthcare Needs Program. VDH is requesting the board's consideration to amend the regulation to revise language to an existing section and to add 2 new sections to the chapter. Approval of this regulatory action would result in amending 12 VAC 5-191 to revise Section 40, which describes the scope and content of the CSHCN program. The revision includes language that describes the adult sickle cell population. The amendments also include the addition of Sections 330 and 340. Section 330 provides language that describes the adult comprehensive pediatric clinic network. Section 340 includes language that describes the scope of the adult comprehensive clinic network. The result of the regulatory amendments to implement an adult comprehensive sickle cell clinic network aligns with the recommendations from the American Society of Hematology to improve the pediatric to adult transition by ensuring qualified physicians in adult care are available to treat sickle cell disease. Establishing regulations for the implementation of an adult comprehensive sickle cell clinic network within the same chapter of existing regulations for other sickle cell programs aligns with where the programs operate within the Virginia Department of Health and where the regulations are administered. The main disadvantage to implementing an adult comprehensive sickle cell clinic network is cost. The General Assembly appropriated $305,000 towards this effort. The $305,000 appropriation mirrors the funding amount of the Pediatric Comprehensive Sickle Cell Clinic Network. Should the board approve the fast track regulatory action, the proposed amendments will be submitted to the regulatory town hall to begin the executive branch review process, consisting of review by the Office of the Attorney General, DPB, Secretary of HHR, and the Governor. The Town Hall will send notification to the appropriate House and Senate committees to be notified about the fast track. Following approval from the Governor, it will be published in the Virginia Register of Regulations for a 30-day public comment period. Within 15 days after the close of the public comment period, the regulation becomes effective, barring no objections from any member of the applicable standing committees of the House or Senate, any member of the Joint Commission on Administrative Rules, or 10 or more members of the general public. Madam Chair, I recommend that the board approve the fast track regulatory action. Thank you very much.
Thank you, Ms. Board. All right, folks, can we get a motion on the table first? Is there a motion to approve?
So moved. Dr. Puritz?
Okay, we have a motion to approve from Dr. Pierce. Do we have a second?
Antigen, seconds.
Okay, we have a second from Antigen. All right, so we have a motion and a second. Now can we have questions and or conversation? No questions? All right, seeing none, I will call for the roll call.
Thank you. Mr. Kreitzer?
Yes.
Thank you. Mr. East?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Yes.
Thank you. Ms. Harrison?
Yes.
Oh, thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Dr. Klein? Dr. Klein?
It looks like her internet went out.
She's muted. Wendy, you're muted.
Yes. Yes. Oops.
Thank you. Dr. Miller?
I'm having trouble.
Yes. Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz?
Yes.
Thank you. Dr. Schuler? Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. And Ms. Whipple?
Yes.
Thank you. Madam Chair, the motion has 15 ayes.
Thank you so much. All right, Ms. Board, we will come right back to you for regulations for state certified doulas.
Yes, Thank you very much, Madam Chair and members of the board, for additional time to present to you the proposed regulations of 12 VAC 5-403 related to the certification of doulas. I would like to share that Consuelo Staten is on the call as well and available to respond to any questions. So Section 32.1-77.1 of the Code of Virginia defines a state certified doula as a trained, community-based, non-medical professional who provides continuous physical, emotional, and informational support to a pregnant person during the antepartum period or during the period up to 1 year postpartum, and who has been certified by a body approved by the board. Section 2.1-77.1 requires the Board of Health to adopt regulations that set forth the requirements for use of the title State Certified Doula and the training and education necessary to satisfy the requirements for certification as a state certified doula. In addition, the code requires the establishment of a public registry of state certified doulas. The primary goals of establishing state certified doula requirements is to improve the birth outcomes of pregnant women and infants in Virginia through community-based doula services and to eliminate maternal and infant mortality racial disparities across the Commonwealth. The rationale for establishing doula certification requirements and implementing a doula registry are as follows. According to VDH data, the 2018 infant mortality rate for Virginia residents is 5 Virginia week 6 per 1,000 live births. The rate is 4.9 for white infants and 9.7 for Black infants. The infant mortality rate for Black infants is 1.7 times higher than the state rate and 2 times higher than that of their white counterparts. Maternal mortality rate in Virginia is 29.5 per 100,000 live births. The rate is 27.7 for white individuals and 52.6 for Black individuals. The March of Dimes supports increased access to doula care as one tool to help improve birth outcomes and reduce the higher rates of maternal morbidity and mortality among women of color in the United States. Establishing training and education requirements for state certified doulas can provide standardization, continuity, and validity in the knowledge, skills, and abilities of individuals practicing as certified doulas. The establishment of a public registry that will list all doulas certified in Virginia may provide assurance to the public that the listed doulas have met the standard certification requirements. Currently, information regarding the number of doulas practicing in the NORA stage for these regulations was published on September 14th, 2020, and the public comment period ended October 14th, 2020. No comments were received during the public comment period. VDH is requesting the board's consideration to adopt these proposed regulations. Approval of this regulatory action would result in creating a new chapter of the Virginia Administrative Code, 12 VAC 5-403, and the following 7 sections therein. Section 10 defines the terms used throughout the regulations. Section 20 describes acceptable use of the title State Certified Doula. Section 30 describes the qualifications for a State Certified Doula. Section 40 describes the minimum standards for a certifying body approved by the Board of Health that will certify doulas, approve training entities, and establish a statewide doula registry accessible by the public. Section 50 describes the curriculum requirements for doula training and education. Section 60 describes Section 70 describes exemption from state certified doula requirements. The result of these regulations will be established requirements for who can use the title State Certified Doula and the training and education requirements for doula certification in Virginia. These regulations also establish the requirements for the certifying entity approved by the Board of Health that will certify doulas, approve training entities, and establish a public registry. This regulatory change is intended to improve the birth outcomes of pregnant women and infants in Virginia through community-based doula services. It is also intended to eliminate the maternal and infant mortality racial disparities across the Commonwealth. Doula support services can positively impact maternal and infant health outcomes and improve maternal mortality and morbidity rates in Virginia. Should the board approve the proposed regulatory action, the proposed amendments will be submitted to the regulatory town hall to begin executive branch review process, consisting of review by the Office of the Attorney General, DPB, Secretary of HHR, and the Governor. Following approval by the Governor, it will be published in the Virginia Register of Regulations for a 60-day public comment period. Upon completion of the public comment period, VDH will prepare the final regulatory action for presentation to the board at a future meeting. Madam Chair, I recommend that the board approve the proposed regulatory action. Thank you very much.
Thank you very much. Do we have a motion? Anybody?
This is Jim. I move acceptance.
All right, we have a sorry. A motion to approve from Jim. Do we have a second?
I'll second it. It's Gary.
All right, and we have a second from Gary Kreitzer. So are there questions or comments?
This is Patricia Kinzer. I have questions.
Please go.
Dr. Harris, I have some questions as well.
Okay, so we'll start with Patricia just because she was first, and then Holly because she was second.
Okay, so first of all, I think this is a good start. I'm concerned that there's still a little bit there's some areas of confusion in this, at least for me, and perhaps we can just talk about them. First area of confusion is in the justification for this, that saying that it will help us understand and regulate all doulas, which is not correct statement. Let's just be clear that this is a state certified doula has to be a community-based doula, which is a different type of doula than just the typical birth doula. So I think we just need to be really clear that in order to get state certification, a doula must be trained at an additional level and be considered a community based doula. But I think because of that, then the rest of the language in the regs gets a little confusing. So maybe that's my first question. I don't know if anyone wants to address that. And if you guys have talked about ways to decrease the confusion there.
Consuelo, if you could unmute to reply in response with the communication that occurred related to this within the work group.
And then while she's unmuting, I'll just clarify that my question is also based on the fact that there is currently only one certifying body in the US that certifies for that level of doula, the community-based doula. So there are other bodies that have education around doula training, but at that level, the community-based doula level, it's only, at least right now to my knowledge, there's only one certifying body. So.
Hello, everyone. This is Consuelo Staten with the VDH team. As far as additional training for community-based training doulas, there are some bodies that will provide that training. But what we wanted to do is to pull together a component that will provide access to training that would be community-based doula training. So I'm not sure if that answers your question, but that's where we are.
I think we just wanted to clarify. So somebody who is trained as a doula by, for example, DONA, which is one of the major certifying bodies in the US, they would not actually fall under this because DONA does not do community-based doula training, whereas that is one of the largest training entities in the US. So therefore, all of those doulas that have done that training will not be able to be state certified. Just want to clarify that, right? Am I correct in that thinking?
Well, there are some other training there are some doula certifying bodies that do provide community-based doula training. So as far as all doulas going through this process, they would need additional training. Exactly.
So I think we just need to be careful in the marketing of this, because this means that to be a state certified doula, this will not allow the majority of doulas who are currently in practice to be certified by the state.
Does somebody want to respond to that?
Consuelo.
Well, I would say that that is correct. Yes.
Patricia, did you have something else, or?
I do. My other question is about the assessment that there's no economic impact. Doesn't there need to be an additional layer of some kind of group involved in monitoring certifying bodies and setting up public registry and such?
Yes, there will be a body that we're working with through the Virginia Certification Board, and we also have a work group that we're pulling together to help in that process. And let me also just clarify that as long as any doula completes the curriculum requirements that we're offering, then they could be part of the certified doula process, the state certified doula process.
But it's my understanding that there's only one certifying body right now that offers that level of training. So unless we're saying that there's a bridge program that they can do that's offered by a different certifying body, then again, it's going to limit a lot of the currently practicing doulas, is my understanding.
Hi, Patricia, this is Linda. I participated or sat in on several of the work group meetings with the doulas, and they had doulas represented across the state. That was not a concern for, at least one that they did not voice at the time when they went through how this program would work or is planning to be rolled out to be certified in Virginia, as well as they need the certification so they can also get reimbursement. And so I don't know if that's something that we need to bring back to that group, but at the time they did not voice that concern.
Well, it has been voiced to me because the wording that was presented to them is different than the wording that we have received. So there has been a change in section, I'll get you the exact number, that changed one piece of the language from what they saw. So that's why it wasn't voiced at that meeting.
And let me also share that the Virginia Certification Board will allow training training from other entities. So we have at least 4 or 5 doula certifying organizations that we're going to be using to help with the training process.
Even though they're not officially considered community-based doula certification programs.
Yes, I guess at this point we're looking at all of those.
I guess I just wonder if we need to go back a little bit, and the concept, this phrasing can perhaps be interpreted to be additionally restrictive, and it might just be me and a few of the other people who have looked at it and voiced their concerns to me, but I might just need to just go back for discussion one more time.
Madam Chair?
Yes, Joe?
I was going to ask Dr. Kinzer if she could point the board to the specific line number that she's referring to with the language?
Yes, so the language that was changed from what was presented to that group is, one second. Line 45. What was originally presented to them read practices pertaining to doula, no. Sorry, I'm giving you the wrong line. Hold on one second. Go ahead to Dr. Purett's question and I'll get back to you, Joe.
Okay. Polly, are you ready?
So yes, I had some of the same concerns that Dr. Kinzer had. I also didn't understand section 403-70, which said they are not required to be certified. I just want to understand. It says this regulation does not require doula to be certified. Does that mean they wouldn't have a state certification, but they could still function as a doula? And how would that affect their ability to come into the hospital, to be reimbursed for their time at the hospital? Is any state certification going to be tied to reimbursement for the majority of doulas who, as Dr. Kinzer said, often just assist during labor? I didn't specifically understand section 70 and then as its broader implications. That was my first question.
Well, any doula in Virginia can provide services. If they choose to move into the state certified process, they can do that as well. And because some doulas have their own practices, and they're also certified within the DONA international process, they can continue to provide services. If they choose to go into the state certified body, then they can do that.
But again, they would have to go through this additional training in order to do that.
Exactly.
Will that restrict any down the road? Will that restrict their ability to be reimbursed? And is that going to cause any issues for the current doulas in terms of the services they already provide, who do not wish to get that additional certification?
Currently, that shouldn't be a problem, that they can continue in providing their own doula services. And if it moves to the point where doulas become state certified, becomes DMAS and reimbursement, that's a separate process.
And lastly, I think I don't know if it was said as in a line of the item or just said as a comment that doulas would eliminate maternal mortality. They certainly would help to eliminate it, but it would not. I just want to make sure. I couldn't find the line in the remarks, but Ms. Ford's presentation, she said they would eliminate maternal mortality, and that's not. I hope that's not within the body of it. I couldn't see it there. I just didn't know if that was more an opinion or part of the body of what doulas would be able to accomplish.
I am looking up those the exact wording in the comments, but we do recognize that there are multiple contributors to maternal mortality.
That was just one of the comments, and that was not, okay, I misunderstood. Thank you.
All right. Do we have anything? I'm sorry. Can we go back? Dr. Kinzer, did you find what you were looking for specifically?
Yes, it is lines 43 through 47. I was told that this looks different than what exactly was discussed in that meeting. And just to clarify, so the multiple national programs, DONA, CAPA, To Labor, Doulegs, for example, they provide a lot of the training, but they don't define themselves as community-based. And so using the phrase on line 45 of community-based doula training and certification means that someone might not be able to get that bridge education from any organization that doesn't define itself as community-based doula training. So we just have to pay close attention to this language and plan for, we might know what we mean right now, but if someone's interpreting this later and it is more restrictive than we mean it to, then that could be a problem.
All right, let me, I'm sorry, is someone else speaking or I'm just getting some interference?
Yes, this is Wendy Klein. I'm unclear. This discussion is leaving me a little confused. Patricia, do you have a specific recommendation for a language change that would make it more clear?
The recommendation from the group of doulas that brought this to my attention was that it simply says on line 45 pertaining to doula training and not have the words community-based. Because then that gives more flexibility to all of the organizations across the country who don't have in their LLC the words community-based doula training.
Patricia, my only concern is the other parts of the regulations. It states that they have to have the training of antepartum care 1 year past. But I mean, there's a lot of other statements at the beginning that make it a community-based doula.
I'm not disagreeing that it shouldn't be about community-based. This is all kind of in the weeds because there is only one organization that calls itself a certifying body for community-based doula training. And so therefore, all of these other groups that are very well established and respected, what we're kind of saying is we're not going to allow them to be part of the training.
No, I agree with you.
It gets a little confusing there.
Yeah, I think that then the regulations may have to be reworked completely because so many different places it makes the case so I'm totally in agreement with you. It makes the case that to get state certification, you have to have more training than most doulas have, even though they're accredited by very good organizations. I'm concerned that just taking it out of line 45 isn't enough, I guess is what I'm saying.
Yeah, I agree. And, again, I don't want to say that we don't want to have a certain level of training. All I'm just concerned about is that if all of a sudden we have this regulation that means that people cannot get trained through a certain group, then what we're effectively doing is we're decreasing the amount of doulas, state certified doulas that can be available to women. And if our point is to enhance wellness for around the perinatal period, let's really do that.
Well, this is Consuelo. Donor International has said that they would provide that type of training. Are you saying that doulas across the state won't be able to sign up for those particular curriculum trainings?
I'm saying I think the wording is confusing because DONA does not define itself as a community-based doula certifying group or training group. So if we're saying they have to have that specific training, but they don't advertise themselves as being community-based, then it gets confusing.
Can I interject here that it appears to me at this point that both Patricia and Holly are making the point that this is not quite ready for prime time and needs a little bit more consideration. Am I adequately reflecting both of your opinions? Patricia, I see a little nod. Yes, no?
I think it probably only needs a little bit of tweaks and perhaps just bringing back to that group that was drawn together in the first place so that they can see this version and give their comments on it.
I would
Holly?
agree.
Okay. So if I understand correctly, then we have a motion and a second on the floor. We can certainly, if that's what the group agrees with, put this down and then give appropriate direction for what needs to happen before it comes back. Can we have a roll call at this point? Remember that the motion and the second are to approve, and that we have members with concerns.
Madam Chair?
Yes, sir?
Just one suggestion, certainly it's up to the board. Another option could be, we could certainly direct the staff to put together a guidance document to give further explanation and clarification around the regulatory provisions. So that's just another option to consider here.
Yeah, I think what I hear Ms. Kinzer saying though is that there's not, that this needs to certainly involve the outside constituency again in its review. Patricia, is that correct?
Just simply because some of the people who were involved in that original group have said that what we are seeing in front of us is slightly different, and those little tiny differences can make a big impact.
And Madam Chair, just
yes, sir.
one other comment that I would make is, and we might want to just turn it back to Heather Board for a second here, is again, this was done in response to legislation, in compliance with legislation that was enacted by the General Assembly. And I would just ask Heather just to kind of review for the board again what the provisions of that legislation were and what we were responding to with this action.
Sure. 1 moment, please. So with this, we were to, apologize, I am moving my screen around. We need to, so it required adoptions that set forth, required the Board of Health to adopt regulations that set forth requirements for the use of title state certified doula, the training and education necessary to satisfy the requirements for certification as a state certified doula. In addition, it required the establishment of the public registry of state certified doulas.
I'm sorry,
And Madam Chair, just one other comment, and then I will be quiet. So again, this is the proposed regulation. So certainly it's the pleasure of the board, but we would be sending if the board did adopt this, we would be sending it out for public comment for 60 days. So it's entirely up to the board. I'm just going to point out that there would be a 60-day public comment period, and to the extent that the issue raised by Dr. Kinzer, we would definitely hear about that during that public comment period, and that would give the staff the opportunity to take all those comments into consideration and bring back tweaks and revisions to this to the board at a future meeting.
I also have another question. Is the Department of Health planning to have a curriculum to help with any additional training that's needed to meet the certification requirements?
Linda, I was going to ask exactly the same thing. I think it sort of begs, given the dearth of such training organizations, it sort of begs that Virginia should have one.
We do have a curriculum.
Let's just clarify that there are multiple groups, national programs that offer training that could fit within this list that's at the end of the regs, but they are not identified as providing community-based doula they're not community-based doula organization, even though they do provide that training. So it's all in the language here. It's not that the resources are not there. It's just that that languaging can be confusing. And if someone wanted to be really restrictive, they could say, oh, we won't accept that body's training because it's not by a community-based doula.
So what I was asking is, if you were trained by one of those programs and it did not meet all the specifications, was the Department of Health planning to also have an additional curriculum or training available to supplement that they can take in order to become certified? That's what I was asking.
Yeah, we were planning or looking at training entities across the state or bodies that might be able to fulfill that requirement. We were not going to pull together our own curriculum. We were going to offer that to people who might be interested in providing that training.
Madam Chairman?
Yes, Mary Margaret.
So I was curious about whether other states do this and what's the practice in other states. I always find that that's helpful to have a basis of comparison. And is 60 hours the right amount of a number of hours? Didn't seem like very many to me, but I'd like to know more about the comparison with other states that have similar programs.
I think 60 hours is pretty typical, but I'll let Consuelo answer that.
Yes, we did the research, and 60 hours is a good body of work as far as curriculum is concerned. And then we also tried to look at some of the newer topics of interest that would be applicable to training for doulas. For instance, trauma-informed training.
If I could clarify for a second, it appears to me we're conflating two issues. I don't want to make 100% sure that that's not the case. Patricia, you are not suggesting that the programs we have do not offer appropriate care. You are suggesting that the semantics here of community-based make it confusing and may make it appear that those programs do not offer what they do, that they're fully vested programs, but the semantics are problematic. Okay, I see you nodding. Okay, thank you.
Madam Chair?
Yeah, I just can't see who's saying Madam Chair. Sorry. Jim, is that you?
Yeah.
Oh, okay.
In consideration, Madam Chair, of a few members of the board concerned here, if it's not paramount that this be passed today, can we step back a degree and let the wording be worked through again so that everybody feels comfortable with this? I highly respect Dr. Kinser's opinion, and not knowing otherwise, I don't want to oppose her feelings. I think she needs to be heard on this.
Jim, I agree with you. I have simply, we can either vote the motion down, or we could ask the person who made the motion to withdraw it, and we could introduce a substitute motion. Whatever is your pleasure.
Madam Chair?
Yes, sir, Mr. Hilbert.
I apologize for imposing on the board's time. I just wanted to point one thing out for clarification. I had asked Ms. Board to talk about the legislation that passed that required this action, and I just want to bring to the board's attention that in that legislation that passed last session, it says that certification requirements for state certified doulas shall reflect national best practices pertaining to community-based doula training and certification. So I just wanted to point out that as far as the legislature and the particular patron of this, they were making the connection in this bill between state certification and community-based.
Certainly, we can modify the language to suggest that there are many ways to reflect being community-based, to clarify what's happening here. All right. Is there anybody else who has anything else to offer? I've lost track now. Who made the original motion?
I think I did, Jim.
All right, Jim, do you want to do we want to vote on that motion as it stands, or do you want to withdraw and offer a substitute motion?
Let's withdraw and substitute that we ask the staff to come back at a future meeting with modified regs.
Okay. Is there a second for that motion?
Schuler, second.
Okay, we have a motion and a second to ask the staff to rework this language, working, I hope, with Dr. Puritz and Dr. Kinzer with their specific concerns. Anything else before we call for the roll call? All righty.
My only concern is, never mind. Nope.
Okay. Am I missing something?
Oh, no, I just didn't know if Joe was trying to message us that like, we have a timeline that are we messing up some timeline, Joe? Is that why you keep pushing us about this?
No, ma'am. There's no timeline.
Okay, I just wanted to make sure that we're not, because I hear you with the fact that we could take public comment. I hear that. I just wanted to make sure there was not something that we're missing here. Thank you.
So, hi, I just, I did want to interject again, as setting through a lot of those work sessions. And we do have the public comment period. Because this was really, because it was brought up, I don't know, and how much degree was, because we started with the proposed legislative action. And so I'm just wondering, would it be better, since we do have this legislative action that we're looking at, to allow it to go to public comment? And that would give the people who are concerned the opportunity to weigh in and voice their concern before we change the language and have it not synced with the current legislative proposal.
Well, I think the motion on the table is to have this looked at one more time. So
okay.
I'm fine either way. Again, I don't think it's a bad set of regs. I think we just have a few little tweaks that need some attention.
All right, I'm going to call for the question. Alex?
Yes.
Roll call.
Mr. Kreitzer?
Yes.
Mr. East?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
No.
Ms. Harrison?
Yes.
Thank you. Dr. Jang?
No.
Dr. Kinzer?
Yes.
Thank you. Dr. Klein?
Wendy?
Yes. Can you hear me? I'm having connectivity trouble.
We can now.
Yes.
We got that.
Dr. Miller?
Yes.
Ms. Pritchard?
Yes.
Thank you. Dr. Puritz?
Holly?
I said yes. Can you hear me?
Now we can.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Schwartz?
Yes.
Thank you. Ms. Waddell?
Now, this is a vote to go back and take another look at it, correct?
Yeah. Yes, ma'am.
Yes.
Thank you. And Ms. Whipple?
Yes.
Thank you. Madam Chair, the motion has 13 ayes and 2 nays.
All right, thank you very much. And I will ask staff to please get with the appropriate board members to get their input about how to move forward on this. All right. Our agenda calls for a break, but I don't think we need one just yet, unless anybody distinctly disagrees. So it is time to hear from Dr. Milano on the annual well-being update. Lori, are you there?
Yep, sorry, I was unmuting. Can you hear me?
I can, thank you. Sorry.
Okay, great. Hi, good afternoon. I think Alex is going to transfer presenter to me. Alex, is that right?
Yes,
You
we
have
made
it.
you the presenter.
Okay, let me, just give me one moment.
Are we muted?
Sorry, I'm having some here we go. Alex, I'm having trouble sharing. I'm not sure what to do.
So in the bottom toolbar, you'll see a share button between start and record.
Yep. Yep.
And you will want to either share the screen or the PowerPoint. So previously you were sharing the screen and that works too.
All right, let me try that again.
So currently we see your screen.
But what are you viewing? What are you?
Your internet browser. I believe we're viewing it. Yep, there it is. Yep.
Okay, hold on one. Here we go. Okay. Okay, good afternoon, everyone. Thanks for the time today. Madam Chair, members of the board, thanks for the opportunity to update you on a lot of the work of the Virginia Department of Health. And I'll start by saying this annual report obviously is not conveying information specific to the COVID-19 response, as that was previously covered by Dr. Oliver. This is our Plan for Wellbeing 2020 update. You've been provided a copy of the annual report, which serves as the state's health improvement plan. As I'm sure you can appreciate, there have been obvious necessary adjustments to a lot of workloads at VDH due to the COVID-19 pandemic. However, there is still a lot of work that's continuing to be done behind the scenes. You've heard about some of it today from some of our colleagues in Family Health Services and Office of Drinking Water, et cetera. So a lot of this other public health work is still is obviously still happening. So the intent of the Plan for Wellbeing, as a reminder, is that we aim our public health efforts and our efforts with partners to going beyond individuals to address health outcomes at a population level. And this requires an understanding of the upstream mechanisms that connect things like social status and health, addressing those factors themselves, examining fundamental environmental conditions, community infrastructure, things like transportation, public safety, housing, parks and rec, et cetera. to address those outcomes. Our local health departments continue to lead the charge, serving as strategists in their communities, and using this plan as a framework. They continue to refine their community health assessments and improvement plans at the local level. As a reminder, the plan is built around 4 aims: healthy, connected communities, a healthy start for children, preventive actions, and a system of healthcare. And this presentation highlights where we're very high level, where we're moving in a positive direction, and where we need some improvement. So in your materials, you'll see a brief narrative report summary, a table that I think is green and orange of metrics, including the original baseline values and the goals, and a technical document which explains more detail about each indicator. Of the 29 measures, when compared to baseline measures reported in 2016, 15 of them, so about half, show improvement, although at varying degrees. Of these, 3 measures, which are highlighted on the screen, have exceeded the goal that was originally set forth in the plan, either this year or a prior year. The remaining 14 measures, which I'll discuss later, persist as areas of needed focus, in that they've evidenced either no change or in some cases have decreased further away from the intended goal. This slide is the 15 measures categorized as improving. However, even though there's been improvement in some cases, it doesn't mean we're completely satisfied with where we stand. For example, the infant mortality rate, so I think was mentioned earlier, for Virginia, for all births has improved, but the infant mortality among Black infants, so it's improved, but it is still quite disparate when compared to that of white infants. I also want to note on this slide the one measure about collaborative health planning, and I bring that up because a lot of that work was, well, it's bread and butter for public health, but was done prior to the COVID-19 pandemic. And I think that collaborative planning has been absolutely instrumental in the COVID-19 response, and having those partnerships and networks in place has been of the utmost importance. And those processes continue. Infant mortality, I'm just going to highlight a few, not all the measures. Infant mortality is defined as the death of an infant before age 1. The mortality rate decreased in 2018. However, the mortality rates by race continue to demonstrate disparities. This map shows a 5-year aggregate of the infant mortality rate among infants in each locality in Virginia. So generally, a greater number of localities in Central Virginia have a higher mortality rate for the team's analysis as compared to other regions. In the United States, infants born to Black mothers die at twice the rate as infants born to white mothers, and unfortunately, this trend is also evident in Virginia. Although the rate of deaths overall is decreasing, as I've said, the disparities exist as illustrated on the slide, and these trends hold true across education levels and socioeconomic status. I wanted to bring attention to a really a massive project that the Office of Family Health Services took on under Heather's leadership, and also I think it was began when Dr. Walker Harris was still the office director. So in 2020, this is a maternal child health needs assessment that's required by law, and in 2020 they completed this assessment as it's required by the Title V block grant. So in addition to quantitative data, the team conducted qualitative assessments in the form of key informant interviews and focus groups throughout the state. So on the surface, via that assessment, we seem to be an overall healthy state with high rankings compared to other states in the country and consistent metrics that generally rank positively. However, they did some intentional disaggregation of data to focus on special population groups throughout this needs assessment process, and there were some disparities revealed. So there are needs, there are strengths, and the data, and you can see some of this online, it's available, and I'm happy to share the link afterwards. There were There are national performance measures that have benchmarks, and you can see where Virginia lies on those performance measures. They looked at categories like health-related social needs, community characteristics, policies and funding regarding maternal child health, the lived experiences of individuals, and diving deeper into equity and disparities. So I just wanted to make sure that this project was highlighted as a real accomplishment during 2020. It also included a qualitative assessment, as I noted, and you can see it was quite the effort. And thankfully, a lot of this was able to be done before the pandemic began, but they continued some of this interactive work more virtually once COVID-19 hit Virginia. And the assessment itself, they were able to develop multiple priorities for the next several years. And again, a lot of this can be, if you have interest, feel free to go online and learn a little bit more. There are focus areas on upstream planning, which is very much in the spirit of the strategic vision of both Dr. Oliver and the health department in general. There were focal areas on community, family, and youth leadership, mental health, looking at finances and economic stability as a root cause, racism at structural and systematic levels, looking at our own data capacity. Obviously, we're a health department, and data is a core component of our work. There's a big focus on reproductive justice. I think that Heather has spoken to at least one strategy that can be used for such support, like the doula program, and strengthening those resources, strong systems of care for children, and other items as well, including oral health. So please, I invite you to look at that report online, and I'm really proud of the team for doing that, especially under such intense circumstances in 2020. Another highlight of a measure is current cigarette and e-cigarette use. I wanted to bring to light some issues that that are still happening, but a little bit in the shadow of COVID-19 right now. So just to talk about a couple of different things today. Tobacco use rates have declined from about 22% in 2014 to 16.5% in 2019. This is a notable improvement. However, the uptake of electronic cigarettes or other types of vaping products continue to be on the rise. Regional differences in smoking also persist, with the Southwest reporting the highest percentage of smokers. We actually, just as a aside, we actually talked in the beginning of the pandemic about the connections in cigarette smoking and vulnerability to COVID-19. So it's these comorbidities really still play out even with infectious disease situations. So moving on to the measures with little or no change, on the screen you can see a list of those. So they've had either no change or in some cases have decreased further away from the goal. It's a little more easier to visualize sometimes in the table. There's a little trend line at the far right-hand column of that document. For example, adults who are overweight or obese is stagnant at 65%. And this is a notable finding given the vaccination campaign we're about to undergo. Is adults receiving their annual flu vaccine is plateaued or stalled at approximately 47%. So only about half of adults, there are different age breakdowns, opt to get a flu vaccine or have access to a flu vaccine in Virginia. And surprisingly, we are one of the stronger states in this adult vaccination metric, but I think about that a lot as we're about to undertake this COVID-19 vaccine campaign and what that means for our planning and strategies to increase uptake for COVID-19. So further investigation into all of these health behaviors and outcomes is obviously still needed. Some of these are just slow going as far as progress is concerned, and we know that many factors play into these measures. And the narrative report also elaborates on some of the income and employment data, and I want to acknowledge the Social Epi team and the Office of Health Equity for providing a lot of that content. And this just highlights the metric that I mentioned of the overweight and obese adult. It slightly increased from 64.7% in 2014 to 66.4% in 2019. And there's also a continued disparity between white non-Hispanic adults and their Black, non-Hispanic, and Hispanic counterparts. Again, another thinking about comorbidities for COVID-19, just to bring context. And lastly, I just want to note a few updates regarding our collective impact work through our partnership with VHHA and other stakeholders through the Partnering for Healthy Virginia Collaborative. If you remember, PHV was founded by VDH and VHHA to impact population health efforts and activities, and the goal is to ensure that every Virginian has a fair and equitable opportunity to achieve optimal health. We've continued that partnership throughout the pandemic this year and have made some strides on some pretty exciting work. And Dr. Oliver might want to elaborate in a couple minutes if there's questions. Two things I want to note. We have continued our Population Health Improvement Collaborative. We continue to grow and expand the partnerships, include stakeholders from local health departments, hospitals, community health coalitions, businesses, foundations, funders. In late 2020, CARES relief funds were awarded to support the implementation of an electronic referral system to connect patients to needed social services. I think this has been mentioned in previous meetings, and this need was identified through PHV's e-referral committee as a tool that can help address some of these health-related social needs by more efficiently, electronically, sometimes, or to pushing referrals, connecting patients to needed services. So this is important always, but an example of its application during the COVID-19 pandemic is to help us support those who may have needs during isolation and quarantine to help ensure that they comply with those quarantine periods to the extent, to the maximum extent. And sometimes folks will have some needs that need support during that time period. We also remarkably continued a learning collaborative virtually around community health assessments and improvement plans, and that team collectively, so we worked with hospital reps and local health department reps to develop a common core set of indicators that will now be analyzed in every hospital and health department community health assessment moving forward. And a goal for the upcoming year is to also have a portal to house those indicators and continue to support members in multiple areas through that collaborative around strategic collaboration, reporting formats, data support, strategies for evaluation, et cetera. And finally, just to give an update on our state health assessment and state health improvement plan process. So this was the last of the annual updates for this current iteration of the plan for well-being. We are behind on our timeline. The state health assessment we aimed to complete that by about now. And I'd say roughly speaking, we're about 6 months behind in that process due to the pandemic. I'm hoping to finish up interviews for a new state health assessment coordinator within the next 2 weeks, and we'll get someone on board in the new year to re-energize and refresh this process. And I look forward to giving you an update when that is complete. And our goal would be to introduce the next version of the improvement plan in early 2022. And the pandemic has definitely given us a lot of opportunity to learn how to do these kinds of assessments and collaborative work virtually. That's definitely different for this, but it's actually given us some practice to reach a wider audience and still obtain timely data and rich information from partners. So that's our summary of the report, and I'm happy to take any questions.
All righty, do we have questions for Dr. Furlano? Well, I will start off, Lori. I'm not exactly sure how to phrase this, and so hopefully you can help me through it. As we look at the decreasing numbers of smokers, but the increasing numbers of users of e-cigarette products, do we track new smokers, like who's young people as they begin the process of smoking? So I guess what I want to know is the overall number going down, or what we're not getting in new cigarette smokers, is that being made up by new e-smokers? Is the arc bending in the right direction?
Yeah, that's a good question. I think I'm certain that we track data by age, so that could give us some information regarding the, and I'm fairly certain they characterize as new smokers, so they can determine, say, what if the question on a national survey is when did you begin smoking, then you can figure that out, that timing. I don't know if Heather Board's still on, but I can follow up with Heather and the tobacco team afterwards. It's a great question.
I'm just curious about the direction in which we're moving, so that.
Yeah, absolutely. We definitely do a lot of work, collaborative work with the Virginia Foundation for Healthy Youth to target youth with campaigns to prevent the start of the behavior. Absolutely. But there were absolutely pretty concerning trends this time last year. So I'll have to check back in with that team.
Thank you. All right, folks, are there other questions? No? All righty then, Lori, thank you very much.
Thank you.
All right. Guys, I'm going to suggest before we move into our other two presentations that we do take a very short break. Somebody's snapping in Madison. Did I miss something?
We need to vote to approve this, right?
Oh, I'm sorry.
Madam Chair.
Yes, I'm sorry.
If
All right.
you don't mind, if we could have a vote on approving this report.
Sure. All right. Can we have a motion and a second to approve the annual health plan for well-being?
This is Wendy.
Okay. Wendy first.
I so move.
And I'll second.
Patricia was second. All right. So the motion by Dr. Klein and a second by Dr. Kinzer, I believe is what I heard. All right. Any further discussion or comments? All right, then roll call, please. Oh, Benita, was that a question?
No, sorry about that.
Okay.
I'm good.
Okay.
Mr. Kreitzer?
Yes.
Thank you. Mr. East?
Tommy, you there?
Mr. East?
Yes.
Thank you. Mr. Edmondson?
Yes.
Thank you. Ms. Hines?
Yes.
Thank you. Ms. Harrison?
Yes.
Thank you. Dr. Jang?
Yes.
Thank you. Dr. Kinzer?
Yes.
Thank you. Thank you. Dr. Klein?
Yes.
Thank you. Dr. Miller?
Yes.
Thank you. Ms. Pritchard?
Yes.
Thank you. Dr. Puritz?
Yes.
Thank you. Dr. Schuler?
Yes.
Thank you. Dr. Swartz?
Yes.
Thank you. Ms. Waddell?
Yes.
Thank you. And Ms. Whipple?
Yes.
Thank you. Madam Chair, the motion has 14 ayes, or 15 ayes.
All right. Thank you so much. All right. Now we'll take a really, really quick break, just like 5 or 6 minutes, and I'll see you back here. Okay, we ready to come back?
We're ready.
I'm told that Heather has an answer to the e-cigarette question before we.
Yeah.
Yes, Madam Chair, Heather Board, I apologize. Some technical issues in getting through before. But I have a little bit of data in response to the question. While we know that the overall trends of smoking, traditional combustible cigarette smoking is decreasing. When we factor in kind of the vaping and e-cigarette use and exposure to nicotine, the rate of nicotine use is skyrocketing at this point. We are still waiting for our data analysis from the most recent Virginia adult tobacco survey that will give us the information as to new smokers. So that data is still forthcoming. However, we should see, and one of the goals of the Tobacco 21 laws that went into effect are to curb the numbers of new smokers, because most people typically smoking as a youth. So upping in their early adult teen years. So upping that rate to 21, we should see that number of new smokers start to decrease as well. And I did want to share that anecdotally, there has been a great deal of concern and discussion amongst tobacco cessation advocates that during COVID-19, we're actually seeing an increase in the number of people who are reverting from vaping back to traditional combustible cigarettes. And some of that is because they, while a lot of them switch to vaping because that's a little more socially acceptable out in social environments, now that they are at home and just around their immediate family and not in as many social outings, they are reverting back to cigarette use. So it's going to be very interesting as we take a look at these numbers to see if there are some blips and changes in tobacco usage.
Thank you very much. That is what I feared. All right, Joe, did you want to introduce Stephanie's update for us? Joe, you guys are muted in Madison.
Yes, Madam Chair, thank you. Before we ask Stephanie Gilliam to provide the budget update, I just wanted to say a few words about the policy recommendations that the board sent to the governor back in late September. We provided the board with another copy of the September 25th letter with the attachment that you sent to the governor conveying the board's prioritized policy recommendations. While VDH never received any specific feedback or response concerning that letter, following some discussions with the administration, the agency did submit several budget amendment requests pertaining to pandemic-related issues, including a substantial amount of newly requested general funds to support COVID-19 vaccination efforts. And you may recall that the board's top priority recommendation to the governor that was submitted on September 25th actually focused on vaccination and made reference to COVID-19. Stephanie Gilliam is going to describe VDH's budget amendment requests that have been submitted to the governor for hopefully for inclusion in his budget bill that'll be released later this month, and that'll be discussed in the General Assembly session. And then in addition, At the specific request of the governor's office, VDH has submitted a budget amendment request intended to address funding issues in the cooperative budget that supports local health departments. As part of the cooperative budget, every city and county in the state has a locality match rate where they have to match a certain percentage of the general funds that they receive, and that match rate is based on local ability to pay. However, those rates have not been regularly updated since they were first established in the 1950s. And this has resulted in a growing number of localities that have seen their cooperative budget match rate remain the same despite significant improvement or decline in their local ability to pay. We consider this budget amendment request to be an opportunity to achieve a net increase in funding for local health departments if all goes well. And Stephanie will walk the board through that. I just wanted to share that feedback with you concerning the policy recommendations that were submitted. Madam Chair, if there are no questions concerning that, I would turn the presentation over to Stephanie.
Are there questions?
Yes, I have one.
Okay, Jim. Yeah.
One of the other issues that was a major feature of the board's program suggestions to the governor had to do with health equity, and there were a number of steps that we were suggesting. And of course, we all recognize that the budget dilemma in 2020 and beyond. But can't we make some sort of more than a gesture, something meaningful that actually attempts to deal with the health equity problems? I mean, obviously, the health equity is a part of the COVID solution, but we're talking about way beyond just COVID having to reduce the inequities in the healthcare system.
Yes, Madam Chair, I'll just say that obviously health equity is a foundational element to everything we're trying to do as a health department. And I know we've discussed this with the board previously. So I imagine that there will be I know there will be many other conversations about health equity at many levels of state government, including in the General Assembly. And just to put into perspective what Jim referred to in terms of the challenges with the budget, I was told by the Secretary's office that out of the Health and Human Resources Secretariat, out of the agencies in HHR, there were more than 200 budget requests submitted, and only 15 of them made the cut. So, so that was the level of scrutiny and the filter that had to, and the hurdle that we had to get over. So anyway, that's really all I can say about that, Madam Chair, at this point.
Okay, thank you very much, Joe. All right, well, with that, then we will move on to Stephanie and her budget update. Stephanie and our budget update.
Good afternoon, Madam Chairwoman and members of the board. Can you hear me all right?
We sure can.
Okay, so again, today I'm going to kind of walk you through the VDH's budget requests that were submitted for the upcoming 21 General Assembly session, and also kind of go over the COVID-related funding that we received to date with a little extra kind of detail. And before I launch into the slides, I did want to kind of explain a little bit about our requested amendments. I wanted to note that there were many ideas for budget amendments this year, obviously, but you know, certainly the agency itself had to figure out its own priorities, and then kind of late in the game, the governor's chief of staff put out the official guidance on what restricted, you know, what we were able to actually submit. And one of the big ones was that there were no new funding initiatives were going to be considered at all. And really anything that would have any chance of success had to address either mandated costs, pandemic response, or unavoidable changes in caseloads. So that obviously limited a lot of what we could put forward. They did also indicate that all those items that were previously funded out of the last regular session in the spring, but were subsequently removed due to COVID, that they would be given priority for restoration if revenues were sufficient. Now, that's definitely not a guarantee that we'll get any of that funding restored, but it means there is a possibility. And we were explicitly told not to resubmit for those requests. I will say I included beyond the presentation at the end, just for your reference, what that listing of items was in case you wanted to go back and look, because again, there is some chance that one of those could reappear in the governor's budget. And just also wanted to note, I mean, again, I think we all realize there are finite resources and a lot of needs throughout the state. But hopefully, you know, one good thing that can come out of the pandemic is the focus is kind of put on the need for public health resources. And hopefully that'll help, you know, make VDH a priority, and that a solid number of that limited amount of budget amendments that were successful, hopefully there'll be some of these I'm going to explain today. And again, the governor's budget does come out in just a few weeks. So we can move on to the next slide. And obviously, I mean, pandemic response is also a huge key priority for VDH. So these first amendments are going to reflect that. And this one, the first is a request to sustain that massive vaccination effort. Again, VDH currently has that state CARES Act funding that we're using. But again, that expires on December 30th. So without knowing if there's going to be another federal fund source that will become available, we've requested that general fund that we'll need to continue once those funds expire. You can see we requested, you know, $30 million in FY21 and $60 million in 22. And I'll say for all of the first four amendments, you're going to see the two on this slide and the two on the next. The amounts noted for FY21 obviously just represent the January to June timeframe. Now, that said, we obviously won't know the outcome of the General Assembly session until at the earliest April. And clearly we can't just not continue our work. But as has been mentioned, we've been working with the governor's office and the Department of Planning and Budget to figure out some stopgap measure so that all of these activities will continue without interruption. And then the second item on this slide is just dealing with the communications needs, again, those media campaigns, whatever's necessary across all kind of COVID activities. And that's also currently funded with the CARES Act. Next slide. So these next two actually center around us taking over for some contracts that VDEM currently holds. These are all also currently funded with the CARES Act dollars. The first one relates to some COVID data modeling contracts. One is with UVA's Biocomplexities Institute to provide epidemiological analysis, and the other is with the RAND Corp, which provides broader survey modeling, literature, and policy reviews. And the second one on here is a contract for communication, but it's got a more specific focus on that equity, diversity, and inclusion piece. Again, the governor's newly created office with that same name of diversity, equity, and inclusion. This was a contract that they really pushed for. And again, VDH is going to look to take that on in January from VDEM. And while we didn't ask for funds in FY22, we feel that the $12.5 million that we've requested in our larger communication effort on that previous slide is sufficient that we can incorporate these same deliverables into that for the FY22 time frame. Next slide. So VDH's Office of Licensure and Certification received a grant from CMS, the Centers for Medicare and Medicaid. It's for surveys and certification activities, and it's so far the only COVID-related grant that we've received that actually requires any amount of match. So we were able to use some vacancy savings for FY21. So we are going to be able to use that grant this year as well. But we didn't want to kind of count on that for FY22 and 23. So we have put in a request that would get us the general fund. And again, it's the entire grant doesn't require a match. It's just a segment of it that relates to Title 19 because the Title 18 piece doesn't require the match. But hopefully that will get approved. Next slide. So first up here we have two language-only amendments. The first one relates to the LARC initiative. So currently we have $3 million in federal TANF funds, but the current language restricts it so that $2 million of it is for the LARCs and the other $1 million is for contraceptives that are not LARCs. So that $1 million component was actually new for FY21. And we basically asked for a paragraph that would allow us flexibility between the two. So far this year, VDH is spending the LARC money much faster than we are the non-LARC money. And we don't want to get to a point that we have to turn people away because we have money in one bucket but not the other. The next one is just a name update. Virginia ADAP changed its name recently to VA MAP, and this is going to correct references in the budget bill accordingly. And then the last one here is tied to a legislative proposal. It authorizes the use of our on-site sewage system indemnification fund to provide loans and grants to repair and improve those systems. And the position would oversee that as well as some other activities. This is actually kind of the one exception that we've got to something that was technically funded out of the last session but removed due to COVID. We've resubmitted the request because now that it's linked to a legislative proposal, we want to be ahead of having that fiscal impact out there because it's a little bit different when it's actually tied to a piece of legislation. Next slide. So the first one here is going to sustain and expand our communicable disease surveillance and investigation efforts across both the Office of Epidemiology and our 35 local health districts. Each district would actually get 2 new positions, an epidemiologist and also a communicable disease nurse. EPI would get 5 new epidemiology program managers. The request also includes 29 FTEs that are for contractor conversions, staff that are predominantly paid with federal grants, and we would just prefer to convert them to FTEs because they're much more stable that way and we don't experience the same kind of turnover issues and loss of knowledge when that occurs. So the second one on this slide is to provide network updates in the local health districts and some of our other regional offices. Their inadequate bandwidth has been impacting the ability of the agency and our public health partners to communicate and share critical information in a timely manner. And it's not kind of all across the board. We've actually, done work at looking at what the needs of the individual health departments are and what will best serve them instead of trying to go with a vanilla approach for everybody, trying to target it in ways that make it as economical as possible for the state, but will really help the districts. Next slide. So this first one is related to another legislative proposal where we're seeking to create a state overdose fatality review team to help developing policy and programs to combat the continuously growing number of overdose deaths in the state. The next one is an FTE-only request. Most of these are similarly converting existing long-term contractors into FTEs. That same logic where, again, you have more stability when you have a full-time state employee. Some of them are also going to help support the regional EMS councils, with more of them kind of moving towards hybrid regional council models where VDH provides some of the staff and some of them are employed by the regional EMS council itself. EMS has the funding for this, but they just don't have the FTEs to get that done. So next slide. So we're going to talk about these a little more in depth, as Joe kind of indicated before. So we've got a couple of slides on these, but so this first one here would allow CHS to carry forward up to $1 million of general fund in balances in any given year because of vacancies that they have over to the next year, and to be able to use that funding to support community-based public health outcome improvement demonstration projects. So kind of target that in the areas where there is the most need. The next one here is, again, that long overdue update to the match rates for the localities for the cooperative budgets in the local health districts. Next slide. So a little background again on those match rates. So like Joe mentioned, they were created in 1954. They were capped at a maximum of 45%. And the logic behind that is, that way the state's always paying more than the locality itself. And they were set at that time at a minimum of 20%. So about a decade later, they came back and the minimum was reduced to 18%. Frankly, I'm not sure any changes were made to the actual rates at that time because no one currently pays below 20%. But regardless, that's how it's set now, is at the 45 and the 18. The rates are based on a formula that essentially starts with that maximum 45% contribution and adjusts it to account for the locality's revenue capacity versus kind of what the state's is as a whole, and then further adjust it to account for the median household income relative to that of the state. Now, this formula, it doesn't account for any sort of health status or health-related needs in the localities. But again, that first budget amendment on the last slide, where we're seeking that carry forward of $1 million to sort of target those at-risk areas, that's where some additional funds could really try to impact those health outcomes. Next slide. So a few insights from revising the rates, just some tidbits of information. So more districts see a reduction in their rate than those that saw an increase. Part of that's due to that maximum cap that was already in place. 8.5 million of that total 10.2 number we're seeking is going to be for the districts with decreasing local match rates. So again, instead of them ultimately losing money because their match rate is lower, we're going to plug that hole with general fund for them. Now, the other 1.7 of that is places where the districts would basically experience an increase in their rate and would thus be entitled to less general fund. So we're seeking to hold them harmless and continue to provide them the same amount of general fund. Again, because when you've spent decades not updating rates, it's not necessarily fair to make somebody's rate jump significantly from one year to the other. Some other kind of interesting things. So 54 of the localities see an increase. 59 of them are going to see a decrease. The decreases are much sharper than the increases, though. We'll say 20 of the districts were already at that 45% cap, and they're going to remain there. 32 additional districts would now have that 45% maximum, but many of them weren't very far from that to begin with. They were in the high 40s already. There are 6 districts that would drop down to that 18% minimum. The average increase is about 6%, but the average decrease is about 10.7%. That's again where I was saying the declines are much sharper. And so again, we've asked for that hold harmless approach, at least for FY22, so that they have time to kind of adjust to what their new rates are. A key point that I want to make here is that $8.5 million would, technically speaking, be converting some of their local match into state general fund. But VDH is hopeful that a lot of the localities would continue the same level of investment. And instead of giving those funds, as match, they would then choose to give them to us as 100% local funds. Hopefully towards, improving health outcomes in their areas. And just to kind of give you a specific example, Newport News currently has a match rate of 41 and some change percent. Their rate would now drop to 28.25%. So that actually equates to a shift of $690,000 from their local match to general fund. So VDH would hope that instead of them, taking that savings out of their local health department, that they would instead choose to continue their same level of support, again, the same amount of dollars they were already giving us, but that extra $690 would then become 100% local funds. So before I move on, does anybody have questions about that part?
Stephanie?
Yes.
This is Joe. Could you just elaborate a little bit for the board on the difference between the co-op, the money in the co-op budget and money that is 100% locally contributed in terms of the ability of the localities to have more flexibility in how the 100% local contribution is spent and targeted.
Right. So their cooperative budget, which again they get a general fund allocation from VDH, and then districts, especially those that have multiple localities, determine the breakout of that allocation, and then these match rates we're discussing is what determines how much local match they get. And there are prescriptive sort of lists of things that they have to accomplish with their cooperative budget. There's a third component that's not really relevant to the rate discussion, but they also earn revenue that's part of that same cooperative budget process. So there are kind of mandatory things that budget has to accomplish, where currently I think we have about 37 or so localities that give us 100% local funds. Some of them are for really specific purposes, because again, the locality can give us money and say specifically that it is for this purpose. Some, for example, in Northern Virginia provide it because they do a salary offset because of what it costs them to keep and attract staff in that market. For a point of reference, local match in FY20 was budgeted to be about, sorry, not local match, the 100% local funding component was about $7.7 million last year. So if we could manage to get the districts to continue with a lot of that $8.5 million, that would be a significant investment in the local health districts. And again, it's not subject to that same cooperative budget requirements, so it could be targeted to more of those sort of health outcome improvement activities.
I have a question real quick, Stephanie. When will localities know about the change in their match?
So again, we won't know the outcome of the General Assembly. Clearly, you know, the support of the administration, I have very high confidence that this is going to be one of the budget amendments that is successful. You know, what happens through the General Assembly is always its own kind of question mark, who knows. But it's certainly, I mean, something that hasn't been looked at or adjusted in decades certainly should be something that gets some attention. But it wouldn't be until that time when sort of we actually knew definitely that this was going to go forward that we would really communicate that. And again, it's because we recognize that, you know, the localities have different timelines for their budgeting. It's part of that same reason why the hold harmless approach was important, right. Is to you know, give localities some measure of time to you know, adjust for this. So, you know, obviously, if we come out and we're in May or June and we know the answer, then, you know, the conversations could start with the local health departments to go back to their localities and say, you know, here's what we know based on the data we operated off of, and start having those conversations, maybe not, you know, having specific dollar amounts, but talking to those, because, I mean, I've got the per locality breakdown. So, you know, you could start having those conversations with, you know, this is what the quote savings would be to your district, and having those, you know, how can we reinvest that instead of the locality pulling it back to do something to benefit the community.
Yeah, I was simply asking, and I think you already acknowledged this, that it would be helpful to know whether you're on the increase or decrease side, because most of us are preparing our budgets in April. It just be useful to know what your possibilities are.
Madam Chair.
Yes, sir.
Just to supplement what Stephanie said, if in fact this does appear in the governor's budget in a couple of weeks, one of our first moves as an agency would be to reach out to the Association of Counties and the Municipal League to sit down and walk them through this, so that they can help us message it out to the localities.
Okay, and I just realized that because she said we were aiming for hold harmless in 22, it wouldn't make that much of a difference for us this year anyway. Sorry.
Okay, do we have any other questions? All right, let's go ahead and move on to the next slide. So here I've just got a couple of technical amendments. The first one is just a net sum zero transfer of some of our non-general fund appropriation between programs. It's just going to line it up better with how we actually execute the dollars themselves. So it's not a big deal. The next two you'll see have dollar amounts attached to them, but they're actually transfers between VDH and other agencies, so that's why they're at a state level seen as a technical amendment. The first one transfers, and I apologize, that should say NGF next to it because it's federal TANF funds, back to DSS. A couple of years ago, they initiated giving us this appropriation in perpetuity, but in actually working through the process in the years, they've figured out that it really gives them no flexibility, and they want to be able to have that. So they've requested that we give it back to them, and they're still intending to give us the funds every year. We're just going to do it in-year transfers instead. The next one involves behavioral health. So they received $1.6 million in general fund for their Revive program for opioid overdose. And they want to transfer $1.3 million of that to VDH, which is the amount they were using to buy naloxone. Basically, they don't have the ability or capacity to efficiently purchase and store large quantities of it. So they just want to go ahead and make it permanent and give it to us and have us handle that for them. The fourth one here is a line of credit that was given for vital records years ago. This was as DMV was getting access to process the records. And, you know, there was concern it might cause a cash flow issue, but that hasn't occurred. And frankly, the line of credit just causes extra reporting requirements. So it's more an administrative burden than a help. So we've just asked that they remove that out of there. And then the last one here would give us base appropriation for the largest of the COVID federal grants we've received. That's one of the ELC grants, which again, the biggest one of those is $213 million. Again, they have a multi-year lifespan. So there is an appropriation request for both 22 and 23. But the main push for this was the legislature was interested in seeing some of these, dollars reflected in the actual budget bill. And without doing something like this, these large amounts of federal grants that we have aren't reflected at all in our appropriation in the actual budget bill. So that's all for the budget amendments. So I'm going to go ahead and move on to the COVID money. And again, Dr. Oliver showed similar slides earlier, but I did kind of update this one where you can see what we've kind of expended year to date of the State CARES Act funds that we've received, which again, we have till December 30th. We've spent about 15.2% as of the end of November. Important things to note here is some of the things like that Unitas contract, the money that's for the Free Clinic Association, and some of the other items, the Carillion Clinic. Those are things that, once we've finished the contract vehicle or MOU with the entity, we'll be able to move those fairly quickly. And just one other thing I wanted to point out here. So you'll see the third one down there is the testing. And in case that number seems kind of low to you, I just wanted to remind you that this is just VDH's share. DGS, their Division of Consolidated Laboratory Services, also received a large amount of funding out of CRF for the testing effort. It's very likely that we will have funds that we're not able to fully utilize, but we're very restricted in what we're able to kind of do with the funding that they've given us. We basically have to use it for the purpose that we've asked for it. But at the state level, they do essentially have a plan to utilize the funds that are left over by putting them into the unemployment trust fund. But I do think there is some hope that perhaps that deadline would get extended, but when we would actually know that is a whole other question. So I'll go to the next slide, which this is, again, those direct COVID federal grants that we have. And I've got a couple extra ones on this list that weren't on the other list because I've got the ones here that don't necessarily have a huge impact on our larger COVID efforts because they're more targeted. One good example is that child nutrition grant. that was literally just to make the payments to individuals in the qualifying, children, adult care and feeding program. So it wasn't something we could use for broader purposes. Same with sort of the Ryan White and things like that. But so you can see kind of the total budget there and then the expenditures. But another key piece here is I've got that sort of column where you can see where the grant expires. So you can see a lot of these, extend well beyond that December 30th timeline of the CRF. So, we're tracking quite normally. And again, like some of them, especially the ELC grants, the reason you don't see much expenditures there is we've, been given the CARES Act relief funds to utilize so that we could preserve these because of their long shelf life. So that's all I had for y'all today. Do we have any other questions?
Anything else for Stephanie? You always do such a nice job for us. Anybody else? All right. Thanks so much, Stephanie.
Thank you.
All right, Joe, you are the last thing for us.
Okay. So during the September meeting, Madam Chair, I briefed you and the board on legislation that had been introduced during the 2020 special session. Now that the special session has been adjourned, just wanted to give you a final update on actions that were taken during the special session that pertain to VDH and public health. Next slide. So there was, in terms of some bills that passed, legislation seeking to increase and improve the amount and type of data that VDH shares with the public concerning communicable disease outbreaks, as well as require various types of healthcare facilities to enact policies to facilitate patient visitation, and also legislation to provide immunity from civil liability for certain types of healthcare providers. Those were all bills that passed during the General Assembly session and were signed into law. In terms of some bills that failed, was legislation seeking to restrict or limit the authority of the board or commissioner during an emergency, to restrict or limit the authority of the commissioner to require vaccination during an emergency. Also, legislation that sought to establish priority groups of essential workers within the code for receipt of COVID-19 testing. Those were all bills that failed, but in a few instances, requirements were placed in the Appropriation Act in place of legislation that failed to pass, and I'll explain some of those to you. Next slide, please. So this was legislation requiring us to make more information available about communicable disease outbreaks on our website, provided that patient anonymity is preserved. This has been implemented. There was an emergency clause put on the bill, so it was effective on its date it was signed. This has been implemented. Our dashboard on our website has been stood up for this purpose. So that is underway and done. Next slide, please. Senate Bill 5090, this was specific to COVID-19. Also requires additional reporting of this type of data. This bill actually doesn't take effect until February 1st. We are working to implement it, though, so that is underway. Next slide, please. So House Bill 5041 and Senate Bill 5042, specific to the COVID-19 emergency, requires nursing homes and hospices to establish protocols to allow patient visits, and the protocols have to address requirements, a long list of requirements that are specified in the legislation. Next slide, please. Similarly, language was put into the Appropriation Act focused on every type of medical facility that we license, except nursing facilities, shall allow a person with a disability who requires assistance to be accompanied by a designated support person at any time during which healthcare services are provided. So we are working on implementing that through our Office of Licensure and Certification. Next slide, please. There was a lot of legislation introduced around civil liability immunity. This is the legislation that passed. It's targeted at hospices, home care organizations, private providers, assisted living facilities, or adult daycare centers. Provides immunity from civil liability in certain circumstances pertaining to COVID-19, and that's summarized on the slide. Next slide, please. So the rest of the slides, for the most part, are bills that failed to pass. You've seen these before. In September, several bills that sought to limit the emergency rulemaking authority of the board and the commissioner. Next slide, please. Same here. A number of bills were introduced. I fully expect that these bills or similar versions of them will be reintroduced in January, along with proposed constitutional amendments for the same purpose. So this issue has not gone away. It's still out there, and it'll be discussed again. Next slide. Testing. So this was legislation that sought to establish a statutory prioritization of essential workers for purposes of having first priority for COVID-19 testing. You can see how the list was defined in the code. This bill did not pass. The next slide, please. And a similar bill, 5109, focused on nursing homes, also did not pass. Next slide, please. But while the bills did not pass, the prioritization is now a matter of law to a certain extent. So this is the language that's summary of the language that's in the Appropriation Act. Requires us to ensure that residents and employees of any nursing home or assisted living facility receive priority for COVID-19 testing. We are to make available testing through the public health channels to ensure that these access to testing is available in these settings, and any testing costs may be billed to responsible third parties. Next slide, please. Again, there were efforts during the special session to place restrictions around the ability to require immunization if necessary. These bills were unsuccessful. Next slide, please. Language was put into the Appropriation Act requiring VDH to convene a stakeholder group focused on the equitable distribution of vaccines or other medications used to prevent or treat COVID-19. And there's a reporting requirement to the General Assembly. This group has been convened. We did submit our initial report to the General Assembly earlier this week, and we will be providing monthly updates as required. Next slide, please. Some other bills that did not pass. You see down at the bottom there, Senate Bill 5118 was focused on the issue around people falling into arrears on paying their water bill and being subject to disconnection. That bill did not pass, but if we go to the next slide, please. Again, language was put into the Appropriation Act. Summarized here, focused on prohibiting service disconnections to residential customers for non-payment under certain circumstances, and requiring customers to be offered a repayment plan for past due accounts. So this was a huge issue during the session, not just on drinking water, but utilities across the board. But our particular interest was in drinking water, given our role there. Next slide, please. And these are the last two bills, two examples of two other items that were introduced but did not pass. Madam Chair, that concludes my presentation. I'm happy to respond to any questions or comments.
All right, folks, any other questions or comments? Joe, thank you for always making sure that this makes sense when it might not otherwise. All right, do we have anything else that anyone else would like to report on? You all have been quite patient today. If no one has anything, I believe we are adjourned. Thanks as always.
Thank you.
Bye-bye.
Bye.
Bye.
Thank you, Madam Chair and members
Take
of the
care.
board.
Thank you.
You all.
Have good holidays. Be safe.
You in the
you.
new year.
You too. Absolutely. Hey, Norm, that was an Are you still there? Did you go away?
I'm still
Is he
here.
gone?
I'm still here.
Oh, that was an abstract that one of my students has been working on, and I was very impressed by the work she was doing. So
Yeah, it was very impressive. Tell her to send that along. It could be useful for our outreach activities.
yeah, I'm gonna ask her to send it on to the emails that you gave me. She's submitted